free treatment for hepatitis C, which was costing immense money. The treatments have also changed from injections to tablets, but then awareness in the public domain was necessary, and that's what we provided. Similarly, in 2019, the Department of Health of Punjab, the Health Minister himself came to Amritsar, and we had a large function to commemorate the World Hepatitis Day. And in the same day, there were about 800 or 900 delegates, all students from, senior students from schools and colleges, who would then understand what hepatitis C is. So thank you very much, all of you being here, and it is a great moment for us, and we hope to have a great meeting today. Thank you, delegates. It's a Sunday morning. You are here this morning to support the meeting, to learn something new, and encourage our speakers. I would request Gunjan to come and carry on with the program. I think we'll start with the lamp lighting ceremony, the inauguration one, and then take things from there.
Good morning, everyone. I, Dr. Gunjan Malhotra,
and I, Dr. Nabaran Singh Sidhu,
welcome you all to this 10th GI Rendezvous 2025, an organization which started with the motto of locally important and globally relevant. Today we are here celebrating the 10 years of academic excellence. GI Rendezvous is a heartfelt commitment to profoundly share and celebrate the incredible advances in GI sciences, bringing together minds to explore everything from the fundamental basics to the most groundbreaking developments. It's a passionate gathering driven by a desire to inform, inspire, and propel our understanding of GI health to new heights.
Now, without further ado, let's begin our first session, Serve with Gastrocity, GI Services Redefined. 6 years back, 5 great minds came together with an idea of an amazing partnership, Serve with Gastrocity, meaning Serve Dapala. The motto of the organization is Health for All. Let's call upon stage Team Servhit to share their views about Serve with Gastrocity, past, present, and future.
So thank you, Naval and Gunjan. So I welcome you all to this. So as she told that 6 years ago, we started with this team service. Serve means Sabka. And with that, we joined our hands, and in association with Parvati Devi Hospital, Mr. Sanjay Maheshwari is there. So we started this organization considering that there should be one platform where all like-minded people should work for the benefit of the general public, and also no person should leave the treatment behind because of a lack of the money. So in this regard, Mr. Sanjay has helped us a great lot, given us a free hand in case there's a poor patient who is not able to afford the treatment. So then he never says no. So whatever the help they can provide, they provide us with that. And with the kind of infrastructure which we have, so I think we can compete with any of the best institutes in the region. I'll just move it forward, and this already Douglas has told us. So just briefly tell what we have done in the past 6 years. Like in the OPD front, we were able to see more than 2 lakh patients in the OPD with the input indoor of 30 patients per 20,000 endoscopies in this past 6 years, and then sigmoidoscopies to the tune of 3,000 and colonoscopies to the tune of 3,000, and then the surgeries, which, yes, so we have done almost 2,500 surgeries in the past 6 years, and then we were lead in majority of the things. Like we were the first one to start with the narrowband imaging, and we were the first one to start with the EUS in the region. Then first to do the laparoscopic ripples in this region, and then advanced hernia programs, and so on and so forth. So I think the important thing here is the word team. The team, which we started as 5, has expanded with now people like Ankush and Shami. They joined as a medical GA, and in surgery we have Dr. Dipanshu Bansal, who is a strong pillar. And this team has expanded, and we intend to go further. And also we have our resident, Dr. Param, who is sitting at the back. So he is the one person who takes care of each and every patient, and whether it is day or night, he is always there. So with this, I hand over the mic to Gunjan and Naval to take the proceedings further.
Thank you, Team Sarvit, for sharing your Odyssey 3 years with us. Every great journey begins with a bold step, and today we take it together. To officially inaugurate the conference, we will now have a lamp lighting ceremony to enlighten the lamp of knowledge, excellence, and prosperity. For this, we would like to invite our distinguished Dr. Jaspal Singh Sandhu, Advisor to Governor of Punjab and also Vice Chancellor LPU, worthy MLA and President Chief Khalsa Diwan, Dr. Inderbir Singh Nijjar, our esteemed IMA President Punjab, Dr. R.S. Sethi, Honorable PMC Member, Dr. Balwinder Singh Bajwa, respected Dr. Pratap Singh Malhotra, Retired Director Principal SGRD IMSR, Mr. Sanjay Maheshwari, Managing Director Srimati Parvati Devi Hospital, Amritsar, Dr. Manjeet Singh Uppal, Vice Chancellor SGRD UHS, and Dr. Anupama Mahajan, Director Principal SGRD, couldn't be here due to some personal commitments, but have sent their good wishes for this conference. I would also like to invite Dr. Team Sarvit to kindly join the dignitaries for lamp lighting. I would also request Dr. Rana Ranjit Singh, Professor and Head Department of Surgery, SGRD, to please come on the stage. Please begin with the lamp lighting ceremony.
I would also request Dr. Pola Singh Sidhu to come on stage for the lamp lighting ceremony.
Dollar. जी डॉक्टर साहब, हाँ जी। यस, गुड। हाँ हाँ, चाहिए जाएगी, चाहिए जाएगी साइड पे।
Thank you, dignitaries, for kindling the lamp of brightness and proficiency. I would now request worthy Dr. Jaspal Singh Sandhu, Advisor to Governor of Punjab and also Vice Chancellor NPU, to graciously come forward and enlighten us with your insightful words.
Thank you so much, Dr. Gurvilas, Dr. Malhotra, my mentor and friend, Dr. Nijjar, and Pula Singh Sidhu, and dear colleagues. It's been a long, long time since I've been a doctor. I've been an academic administrator and a bureaucrat for almost 15 years. And I don't think I remember much of medicine now, but still, it's an honor to be invited to inaugurate this conference. I've been associated with GI Rendezvous for a very, very long time because they used to conduct awareness programs around the University of Amritsar on a regular basis. And it was very well taken, and it was actually eye-opening for our faculty as well as students. It's an open offer now because GNDU had about 17,000 students, and the audience would be about, maybe when they used to have this CME programs, maybe about 200-300. It's an open offer to you that if you want to come to LPU, we'll give you an audience of not less than 5,000 at one go. And so it's so the total number of students, there are very many. If you want a bigger one, even 40-50,000 would be okay. But 5,000 in our auditorium would be just enough, and I think they'll receive it very well also, because you'll have message going throughout the country. And the next program of awareness should be in LPU, and it will be an honor to host you. I don't know much of GI, but I do know that the gut plays lots of roles, and if you're comfortable with the gut, you are a happier person. If the day you are uncomfortable, then your psychology also goes wrong, and the reverse is also true. Psychology plays a lot in gut health also, because I go on traveling Guruvlas on a regular basis, so that is another thing that happens. And thank you for inviting me, and with eminent people like Dr. Pula Singh and Dr. Nijjar, I don't think I have much to say, but it's an honor to be part of this organization. And we look forward to because our session starts on August first week. Anytime after August first week, you can have a series of awareness programs to items far bigger and than what you will find in Amritsar. It will be an honor to host you there, sir. Thank you so much.
Thank you, sir, for your words of wisdom. Now we request our distinguished Dr. Inderbir Singh Nijjar, MLA and President Chief Khalsa Diwan, to please ignite our spirits with their illuminating words.
Dr. Jaspal, Dr. Malhotra, Dr. Sidhu, other senior doctors, and the team of GI Rendezvous, Sarvit, and all the delegates. It's indeed a pleasure to be here amongst all of you. And for a doctor to be back amongst doctors is a homecoming, especially for the last 7-8 years I've been busy with my politics. So it's always a pleasure when I come back to you. So because you invited a politician, so I guess we have to be discussing a bit of everything. On the national level, I would like to say that we are faced with this threat of Pakistan, terrorism across the border, and no threat can be faced without unity, without love, without affection. So what I'm trying to point out is that we should be united against against enemy, common enemy. So although it's a very uncomfortable question, but what's happening in our country is something which can be avoided. We have to be one. We have to be not only one, we have to be seen to be one also. Second thing I would like to, because it's in the news these days, what's happening on the waterfront in Punjab. So we have delegates from outside Punjab So just a bit of knowledge I would like to share with you, that the water should be distributed according to the principle of riparian state. And what's a riparian area actually. So what's a riparian area? A riparian area is a flood area. And what's a flood area? A flood area is that area over which the water spreads during the rainy season, during floods. That's a riparian area. That's a riparian principle. So it's presumed that a riparian area or a state or a country would benefit from the rivers that flow through it. But that has been sort of abandoned in our present situation, because this Organization of States Act, which the law was created, and it was decided that in a certain way the interstate rivers water would be distributed. But if you look at Punjab, then Punjab has no interstate dispute with anyone, because the rivers flow through Himachal and then on to into Punjab. And the two riparian states are Himachal and Punjab, upper riparian and the lower riparian. And Haryana and Rajasthan don't figure in this. So, but then whatever forefathers thought was right was done. And this is one thing which I would like to point out, that for a change, we've not been able to convey our stand well. Punjabis have not been able to convey our stand well throughout the country. We want to say we will not give a drop of water. Whereas the situation should be that we don't have any water to spare. So two different things, you know. If we talk about we don't have a water, we want to give you a drop of water, then we are behaving in a very belligerent way which no one likes. So that's two things. Second thing is, third thing in fact is that now that we come back to our doctrine, and I think prevention is better than cure, we all know that. And some time back, it was some years back in fact, that I read that 50% of diseases in India are avoidable because they're communicable diseases. And we lose up to 6% of our GDP because of this. So I'm sure that we have a lot of work going to schools and sending out brochures and making documentaries. But probably more important would be talking to your patients on a daily basis. So this thing has to be conveyed to people that staying in dirty, filthy conditions will not get us anywhere. And now that we have this dengue season and the chikungunya season on us, we realize that people ask for fogging, whereas you and me know that fogging has absolutely no benefits. And what we require is that we should avoid stagnant water, which people don't know. We don't know that the tray beneath the fridge is probably the most likely place for a mosquito to breed in this season. So these things have to be communicated to people, and the best way to do it is in your daily practice, inculcate it in your daily practice. And another thing I'd like to share is that yesterday I had this small dinner party was there, and I was invited too. And I met a lot of doctors, especially Dr. Chaudhary was there. And he comes to me and he says, are you fond of fairs? I said, yes, I'm very fond of fairs. So he incidentally, and Amitabh was there too. So we had a lot of discussion on poetry. And all doctors are actually artists. You may not know it, but we are artists. You look at a very ordinary person, and when you see that person in his clinic, the way he's weaving his magic of medicine, or you go to a theater and you look at a surgeon, how he's weaving, how he washes, how he puts on his gown, how he handles his instruments. He's a changed man. So we are all artists, and we should be proud of it. And of course, poetry and art is also important in its own rights. And last but not the least is the discipline part. I think we should really punctual with the time. I make it a point that whenever I visit a school, I am on time, because I have to tell the students to be on time, so I have to be present myself. So Indians as such, I would say, the subcontinent as such, we are not particular with the time, which is very important. Time management is very important. So when you give an appointment, when you give a time, then you should be there. That's about it. And thank you for listening to my ramblings. And it's always a pleasure coming back to you. Thank you so much. Have a good day.
Thank you, sir, for enlightening us. Moving on, I would like to call upon stage Honorable IMA President Punjab, Dr. R.S. Sethi, to please offer some guiding remarks.
My senior doctors, my colleagues, Sarah team, congratulate Saran team. ये हर साल awareness programs और जो academic feast every year they are doing और बहुत बढ़िया program करते हैं बच्चे जाते हैं स्कूलों जाके भी कई program करते हैं so I congratulate them मैं सिर्फ दो गल्लां करनी भाई भी बनाया कि डॉक्टर रिलेशनशिप ते डॉक्टर पेशेंट रिलेशनशिप बहुत जरूरी है आजकल के हालात के तुसीं कल परसों भी अंबरसर देख रहे हो डॉक्टर अगर तू कोई एडमिनिस्ट्रेटर तो होंदा नहीं है डॉक्टर एक डॉक्टर होंदा बड़ा उन्हें टैक्नीकल काम करना उत्थे ही मार खा जाता है कोई परमिशन लैनी है कुछ करनी है लेकिन बाद में प्रॉब्लम फस जाता सो आपां नूं इत्ते इस चीज़ का बहुत ख्याल रखना रिसर्च है साथ जो भी ਜਿਹੜੇ डॉक्टर्स हॉस्पिटल चला रहे हैं ਜਾਂ अपना पर्सनल कर रहे हैं उन्होंने एक एडमिनिस्ट्रेटर हायर करना बहुत जरूरी हो गया है जिन्होंने सारी नॉलेज हो ताकि वो कोई भी प्रॉब्लम जी है फेस कर सके दूसरा डॉक्टर रिलेशनशिप बहुत जरूरी है कि साढ़े असी क्यों बात करते हैं एक डॉक्टर दूसरे डॉक्टर की बरबई करी जाए एक थान दूसरी थान ही करी जाएगा लेकिन बहुत गलत गल असी हर डॉक्टर की आपस में असी जे आपस में एक दूसरे की इज्जत नहीं करा तो साड़ी लोगों के वो चीज़ नहीं बन सकती तो एक पूरी इंट्रोस्पैक्ट की गल है मैं बहुत शॉर्ट च कहांगा अपने आप को अपने अंदर ही इंट्रोस्पैक्ट करना चाहिए फिर उत्थे अपने आप ही जवाब देते बाकी डॉक्टर है डॉक्टर पेशेंट रिलेशनशिप वो तुसीं कर ही रहे हो सारी टीम वाले काफ़ी कर रहे हैं पर जिन्हें भी मैं सुना उन्होंने पूरे पेशेंट किया वही चीज़ां जड़ियाँ सारियाँ करनियाँ चाहिए वो जो आप करनी तुसीं कर भी रहे हो हर डॉक्टर को करना चाहिए ये नहीं कहता है
Thank you, sir, for your pearls of knowledge. I would now request respected PMC member Dr. Balwinder Singh Bajwa to kindly share some encouraging and inspiring words.
मेरे बहुत ही सत्कारयोग डिग्निटरीज डॉक्टर जसपाल सिंह संधू जी डॉक्टर निज्जर जी डॉक्टर भोला सिंह जी डॉक्टर सेठी जी and all my respectable honorable dignitaries और सारिਆਂ ਨੂੰ ਅੱਜ ਸਵੇਰ ਦੀ ਗੁੱਡ ਮਾਰਨਿੰਗ ਸਤਿ ਸ਼੍ਰੀ ਅਕਾਲ ਅੱਜ ਦਾ ਦਿਨ ਸਾਰਿਆਂ ਵਾਸਤੇ ਖੁਸ਼ੀਆਂ ਦੇ ਖੇੜਿਆਂ ਦਾ ਬਣਿਆ ਤੇ ਮੈਂ ਇਹ ਗੱਲ ਕਹਿਣੀ ਚਾਹਾਂਗਾ ਜਿਵੇਂ ਕਿ ਡਾਕਟਰ ਸਾਹਿਬ ਨੇ ਡਾਕਟਰ ਨਿੱਜਰ ਜੀ ਨੇ ਦੱਸਿਆ ਕਿ ਪ੍ਰੀਵੈਂਸ਼ਨ ਇਜ਼ ਬੈਟਰ ਦੈਨ ਕਿਉਰ ਅੱਜ ਦੇ ਇਸ ਦਿਨ ਤੇ ਜਦੋਂ ਕਿ ਯਾਰ ਆਪਣੀ 10ਵੀਂ ਵਰ੍ਹੇਗੰਢ ਮਨਾਉਣੀ ਜਾ ਰਹੀ ਹੈ ਤਾਂ ਉਹਦੇ ਵਿੱਚ ਇਹ ਪਿਛਲੇ 10 ਸਾਲ ਦਾ ਲੇਖਾ ਜੋਖਾ ਜੋ ਡਾਕਟਰ ਸਾਹਿਬ ਨੇ ਦੱਸਿਆ ਕਿ ਇਹਨਾਂ ਦਾ ਪ੍ਰੀਵੈਂਸ਼ਨ ਇਜ਼ ਬੈਟਰ ਦੈਨ ਕਿਉਰ ਉਸ ਮੋਟੋ ਤੇ ਇਹਨਾਂ ਨੇ ਜੋ ਅਵੇਅਰਨੈਸ ਕੈਂਪਸ ਲਗਾ ਕੇ ਜੋ ਡੇ ਸੈਲੀਬ੍ਰੇਟ ਕੀਤੇ ਲੋਕਾਂ ਨੂੰ ਅਵੇਅਰ ਕੀਤਾ मैं समझदा हाँ कि वो एक क्यूरेटिव पार्ट नालों ज़्यादा इंपॉर्टेंट पार्ट हैगा जिहदे विच असीं लोकां नूं जिहड़ियां अज दे लाइफ स्टाइल दे विच जिहड़ियां बीमारियां आ रही ने जिस तरह दस्सिया गया कि लिवर दे विच फैटी लिवर है वायरल हैपाटाइटिस है जां इरीटेबल बाउल दीयां जिहड़ियां डिजीज़ हैगियां जां साडा कोलन केयर दी हैगी कैंसर दी हैगी आ पैंक्रिया दी कैंसर दी हैगी आ सो ये चीज़ां सारियां जिहड़ियां हैगियां असीं मतलब लोकां नूं अवेयर करके एटलीस्ट आपां बहुत वड्डा एक योगदान पा सकदे हां इन्हां बीमारियां तो बचण वास्ते दूसरा इन्हां ने जिहड़ियां हैगियां सर्वहित गैस्ट्रोसिटी ने जिहड़ी 6 साल दे विच आपां इन्हां ने जिहड़ी एजुकेशन दे के जिहड़ियां ट्रेनिंग दे के प्लस जिहड़ियां हैगियां प्रीमियर हैल्थ केयर फैसिलिटी जिहड़ियां इन दा GI वो भी ये मतलब प्रशंसा के पात्र ने सो मैं इन्हों बहुत बहुत बधाई दिंदा हाँ नाल ही मैं गल कहना चाहांगा बतौर PMC रिप्रजेंटेटिव कि एक चीज़ बड़ी कॉमन जी चल रही है और सर कौंसल के भी डे टू डे सानू जिहड़ियां लोकां दियां मतलब कंप्लेंट्स आ रही ने कि डॉक्टर्स साडे बड़े गलत ढंग दे नाल अपनी एडवरटाइजमेंट कर रहे हैं उस बड़े अच्छे मतलब एस्टैबलिश्ड हॉस्पिटल्स डॉक्टर्स ਜਾਂ ਸਾਡੇ ਨਵੇਂ ਜਿਹੜੇ ਕਮਿੰਗ ਯੰਗ ਡਾਕਟਰਸ ਉਹ ਛੋਟੇ ਛੋਟੇ ਵਹੀਕਲ ਜਿਸ ਤਰ੍ਹਾਂ ਕੋਈ ਆਟੋ ਰਿਕਸ਼ੇ ਵਾਲਾ ਹੈਗਾ ਜਾਂ ਕੁਝ ਉੱਥੇ ਹੈਗਾ ਬੱਸਾਂ ਦੇ ਪਿੱਛੇ ਆਪਣੇ ਬੈਨਰ ਲਾ ਕੇ ਜਾਂ ਆਪਣੇ ਛੋਟੇ ਛੋਟੇ ਲਾ ਕੇ ਉਹ ਆਪਣੀ ਐਡਵਰਟਾਈਜ਼ਮੈਂਟ ਕਰ ਰਹੀ ਹੈ। ਮੈਂ ਸਮਝਦਾ ਹਾਂ ਕਿ ਇਹ ਚੀਜ਼ ਉੱਥੇ ਵੀ ਵਿਚਾਰੀ ਜਾਂਦੀ ਹੈ ਕਿ ਇਹਦੇ ਨਾਲ ਸਾਡੀ ਜਿਹੜੀ ਮੈਡੀਕਲ ਫਰੈਂਡਲੀ ਦਾ ਜਿਹੜਾ ਇਮੇਜ ਆ ਉਹ ਥੋੜ੍ਹਾ ਜਿਹਾ ਡਾਊਨ ਹੋ ਰਿਹਾ। ਸੋ ਇਹਦੇ ਵਾਸਤੇ ਵੀ ਸਾਨੂੰ ਕੁਛ ਨਾ ਕੁਛ ਆਪ ਸੋਚਣਾ ਪਏਗਾ ਕਿਉਂਕਿ PMC ਤੁਹਾਡੀ ਆਪਣੀ ਰੈਗੂਲੇਟਰੀ ਬਾਡੀ ਹੈ। ਜੇ ਅਸੀਂ ਕੋਈ ਐਕਸ਼ਨ ਵੀ ਲਵਾਂਗੇ ਤਾਂ ਕਿਹਤੇ ਲਵਾਂਗੇ, ਆਪਣੇ ਤੇ ਲਵਾਂਗੇ। ਕਿਉਂ ਨਾ ਕਿ ਅਸੀਂ ਖੁਦ ਆਪਣੀਆਂ IMA ਬ੍ਰਾਂਚਿਸ ਦੇ ਵਿੱਚ ਸਰ ਬਹਿ ਕੇ ਇਹੋ ਜਿਹੇ ਡਿਸੀਜਨ ਲਈਏ ਕਿ ਆਪਾਂ ਇਹ ਕੰਮ ਨਾ ਕਰੀਏ ਕਿਉਂਕਿ ਸਾਡਾ ਸਮਾਜ ਦੇ ਵਿੱਚ ਬਹੁਤ ਉੱਚਾ ਸਥਾਨ ਹੈ। ਅਸੀਂ ਉਹਨੂੰ ਬਰਕਰਾਰ ਰੱਖੀਏ, ਆਪਣੀ ਸਾਖ ਨੂੰ ਹੋਰ ਨਾ ਡਿੱਗਣ ਦਈਏ। ਆਲਰੇਡੀ ਲੋਕਾਂ ਦੇ ਵਿੱਚ ਸਾਡੇ ਬਾਰੇ ਜੋ ਇਮੇਜ ਬਣਦਾ ਜਾ ਰਿਹਾ ਸਾਰਿਆਂ ਨੂੰ ਪਤਾ ਹੀ ਹੈ। ਸੋ ਇਹ ਉਚੇਚੇ ਤੌਰ ਤੇ ਮੈਨੂੰ ਇਹ ਸਾਡੀ ਅੱਜ ਦੀ ਮੀਟਿੰਗ ਵਿੱਚ ਵੀ ਸਾਰੀ ਗੱਲ ਹੋਈ ਸੀ ਕਿ ਇਹ ਚੀਜ਼ ਨੂੰ ਅਸੀਂ ਸਾਰੀਆਂ ਬ੍ਰਾਂਚਾਂ ਵਿੱਚ ਰੱਖਣਾ ਚਾਹੀਦਾ ਹੈ ਕਿ ਜਿਹੜੀ ਇਹ ਐਡਵਰਟਾਈਜ਼ਮੈਂਟ ਅਸੀਂ ਕਰ ਰਹੇ ਹਾਂ ਇਹਨੂੰ ਰੋਕਿਆ ਜਾਏ। ਸੋ ਦੂਸਰਾ ਮੈਂ ਇਹ ਕਹਿਣਾ ਚਾਹਾਂਗਾ ਕਿ ਗਵਰਨਮੈਂਟ ਆਫ ਇੰਡੀਆ ਨੇ ਇੱਕ ਰਜਿਸਟ੍ਰੇਸ਼ਨ ਜਿਹੜੀ ਹੈ ਨੈਸ਼ਨਲ ਲੈਵਲ ਤੇ ਪੱਧਰ ਤੇ ਅੰਡਰ NMR ਸ਼ੁਰੂ ਕੀਤੀ ਹੈ ਜਿਹਦੇ ਵਿੱਚ ਇਹ ਮੈਂਡੇਟਰੀ ਹੈ ਫॉर ਆਲ ਦਾ ਡਾਕਟਰਸ ਟੂ ਰਜਿਸਟਰ। ਉਹਦੇ ਨਾਲ ਇਹ ਹੋਊਗਾ ਕਿ ਇੱਕ ਯੂਨੀਕ ID ਜਿਹੜੀ ਹੈ ਸਾਨੂੰ ਦਿੱਤੀ ਜਾਊਗੀ ਔਰ ਉਸ ਯੂਨੀਕ ID ਦਾ ਬੈਨੀਫਿਟ ਇਹ ਹੋਊਗਾ ਕਿ ਸਾਡੀ ਆਲ ਓਵਰ ਇੰਡੀਆ ਪਹਿਚਾਣ ਹੋਊਗੀ ਕਿ ਅਸੀਂ ਕਿੱਥੇ ਬੈਠੇ ਹਾਂ, ਸਾਡੀ ਡਿਗਰੀ ਕੀ ਹੈ, ਸਾਡੀ ਕੁਆਲੀਫਿਕੇਸ਼ਨ ਕੀ ਹੈ। ਔਰ ਦੂਸਰਾ ਇਹਦਾ ਬੈਨੀਫਿਟ ਇਹ ਹੈ ਕਿ ਅਸੀਂ ਇੱਕ ਸਟੇਟ ਤੋਂ ਦੂਜੀ ਸਟੇਟ, ਦੂਜੀ ਤੋਂ ਤੀਜੀ ਕਿੰਨੀਆਂ ਮਰਜ਼ੀ ਮਲਟੀਪਲ ਸਟੇਟ ਦੇ ਵਿੱਚ ਅਸੀਂ ਆਪਣੀ ਜਿਹੜੀ ਹੈ ਉਹ ਲਾਇਸੈਂਸ ਜਿਹੜੀ ਲੈ ਸਕੇ ਪ੍ਰੈਕਟਿਸ ਕਰ ਸਕਦੇ ਹਾਂ। ਹੁਣ ਅਸੀਂ ਵੇਖਦੇ ਹਾਂ ਨਾ ਡਾਕਟਰ ਜਿਹੜੀਆਂ ਕਰਦੇ ਹਾਂ ਲਾਈਵ ਵਰਕਸ਼ਾਪ ਕਰਦੇ ਹਾਂ, ਸਾਡੇ ਕੋਲੋਂ ਜਿਹੜੇ ਸਾਡੇ ਸਰਜਨ ਬਾਹਰੋਂ ਆਏ ਹੁੰਦੇ ਨੇ ਔਰ ਅਸੀਂ ਉਹ ਆਪਣੀ ਸਟੇਟ 'ਚ ਕਰ ਰਹੇ ਹਾਂ ਔਰ ਉਹਨੇ ਥੋੜ੍ਹੇ ਜਿਹੇ ਟਾਈਮ ਦੇ ਵਿੱਚ ਸਾਨੂੰ ਪਰਮਿਸ਼ਨ ਨਹੀਂ ਮਿਲਦੀ। ਸੋ ਉਹ ਜਿਹੜੀ ਅਸੀਂ ਐਕਟੀਵਿਟੀ ਕਰਦੇ ਹਾਂ ਡੈਟ ਬਿਕਮ ਇਲੀਗਲ। ਸੋ ਜੇ ਅਸੀਂ ਅੰਡਰ NMR ਜੇ ਅਸੀਂ ਰਜਿਸਟਰ ਹੋ ਜਾਂਦੇ ਹਾਂ ਤਾਂ ਆਪਾਂ ਪੰਜਾਬ ਦੇ ਵਿੱਚ ਵੀ ਲਾਇਸੈਂਸ ਲੈ ਸਕਦੇ ਹਾਂ, ਹਿਮਾਚਲ 'ਚ ਵੀ ਲੈ ਸਕਦੇ ਹਾਂ, ਹਰਿਆਣਾ 'ਚ ਵੀ ਲੈ ਸਕਦੇ ਹਾਂ, ਦਿੱਲੀ ਵੀ ਲੈ ਸਕਦੇ ਹਾਂ, ਐਨੀਵੇਅਰ ਇਨ ਇੰਡੀਆ। ਸੋ ਉਹਦਾ ਇਹ ਬੈਨੀਫਿਟ ਹੈਗਾ। ਸੋ ਮੇਰੀ ਰਿਕੁਐਸਟ ਹੈਗੀ ਹੈ ਕਿ ਜਿਹੜੇ ਡਾਕਟਰ ਅਜੇ ਤੱਕ ਰਜਿਸਟਰ ਨਹੀਂ ਹੋਏ ਹੋਣ, ਇਹਦੇ ਵਿੱਚ ਕੁਛ ਨਹੀਂ ਹੈਗਾ। ਤੁਸੀਂ ਪੋਰਟਲ ਖੋਲ੍ਹਣਾ, ਪੋਰਟਲ ਖੋਲ੍ਹ ਕੇ NMR ਦਾ ਉਹਦੇ ਵਿੱਚ 2-3 ਚੀਜ਼ਾਂ ਚਾਹੀਦੀਆਂ ਨੇ। ਇੱਕ ਤੁਹਾਡਾ ਹੈਗਾ ਆਧਾਰ ਕਾਰਡ, ਇੱਕ ਤੁਹਾਡੀ ਡਿਗਰੀ, ਇੱਕ ਪ੍ਰੀਮੀਅਰ ਡਿਗਰੀ ਜਿਹੜੀ MBBS ਦੀ, ਅਤੇ ਤੀਸਰਾ ਹੈਗਾ ਤੁਹਾਡਾ ਜਿਹੜੀ ਹੈ ਰਜਿਸਟ੍ਰੇਸ਼ਨ ਆਫ ਦਾ ਸਟੇਟ। ਦੇयर इज नो ਫੀ, ਕੋਈ ਫੀਸ ਨਹੀਂ ਹੈਗੀ ਇਹਦੇ ਵਾਸਤੇ। ਸੋ ਇਹ ਆਪਾਂ ਸਾਰੇ ਕਰਵਾਈਏ। ਔਰ ਅੱਜ ਦੀ ਇਸ CME ਦੇ ਵਿੱਚ PMC ਨੇ ਜਿਹੜੇ ਹੈਗੇ ਆ 7 ਕ੍ਰੈਡਿਟ ਟਾਸਕ ਦਿੱਤੇ ਆ ਉਹਨਾਂ ਡਾਕਟਰਾਂ ਜਿਹੜੇ ਪਾਰਟੀਸਪੇਟ ਕਰਨਗੇ। ਸੋ ਇਹਨਾਂ ਲਫ਼ਜ਼ਾਂ ਦੇ ਨਾਲ ਮੈਂ ਤੁਹਾਡਾ ਸਾਰਿਆਂ ਦਾ ਤਹਿ ਦਿਲ ਤੋਂ ਧੰਨਵਾਦੀ ਹਾਂ। ਥੈਂਕ ਯੂ ਵੈਰੀ ਮਚ।
Thank you, sir, for your priceless words. Ulcerative colitis is a relentless reminder that even the gut can wage war within. Moving on to our next session, let's call upon stage Dr. Abhishek Deo to enlighten us on the topic ulcerative colitis, treatment, pitfalls and solutions, Indian perspective. We welcome you on the stage, sir.
Good morning, everyone, and I would like to thank the Servit and Rendezvous team for inviting me. I've been coming every year since 2015. I've been here ever since then. I think it's an amazing achievement for them to carry on and impart so much value to the world of gastroenterology and also to the general healthcare in Punjab. So today I'm going to talk about ulcerative colitis as what the Indian perspective is, and I'm going to actually try and make things kind of less academic in the sense that I'm not going to talk in terms of many studies and many trials and talk of guidelines. So I've put a disclaimer here that some of this is going to be my experience, what my colleagues have felt and what they have undergone, and some will also be data backed. Just for a background, I worked in the UK for many years before moving to India. Now I'm at the cusp of having worked both places and see how IBD is treated in both these countries. So traditionally in India, IBD was thought to be virtually very low incidence. There was very little attention paid to it. And if you talk to my father, who was a physician who graduated in the 60s, for them ulcerative colitis was a very minimal thing. They did not even think of it as a condition which would cause any harm. Right now the data is getting more and more, and we understand more about how the IBD situation in India is. Now we have IBD task force, we have population-based surveys, we have also hospital registries, mainly they are inpatient registries. In 1986, the first survey in India was done in IBD. Roughly 1,259 papers were analyzed, and they there were a couple of charts showing how many patients were actually having IBD and how many of them actually had ulcerative colitis and how many had Crohn's disease. I'm sorry, the charts did not come through. So moving on, so how does IBD present? Inflammatory bowel disease or ulcerative colitis, what we're seeing more in North India, it actually presents with, usually it's a chronic history, a few months history of people having some diarrhea, they have rectal bleeding, they have stool mixed with blood often, the diarrhea can persist for more than a few weeks, few months. There's also tenesmus, which is feeling when complete evacuation, there's urgency in running to the toilet, there's increased frequency. They can also develop fistulas and strictures. And there's a course will be, sometimes it will be good, sometimes bad. So this is what we call a relapses and flares and then remission. So if you talk to the patient, they'll say, we have had this problem for a few weeks and things have got better and things have come back again. And I think earlier they used to be treated for all sorts of things, but now we are more aware and we tend to investigate them a lot more quicker. So how do we diagnose? This is a picture of a patient with distal colitis. You can see the top part of the image, it looks normal bowel. The lower part of the image has got ulcerative colitis, and there's a biopsy needle there. We take a biopsy and then we analyze and we confirm the diagnosis of ulcerative colitis on this. Treatment-wise, there are many modalities. There are new and new treatments coming up. In the West, it is a major issue, major problem, major healthcare burden. So a lot more new medications are coming out. But the data doesn't exist in India to say how good or how bad this medication in the population is. I'm not going to talk a lot about treatment in detail, but just skim through it because it's a short time. So the treatment for the baseline of treatment of ulcerative colitis has been 5-ASA, which is mesalazine or mesacol or asacol or multiple different brands available. And that has been the background of treatment globally everywhere. That's every patient should be on if they can tolerate it. They come in both flavors. They come in oral tablet form, they come in suppositories, they come in enema form, they come in liquid gel form. So they come in all different kind of preparation. We tend to use this in combination, but unfortunately in Indian context, rectal enemas are rectal preparations are very infrequently used. And there's a social stigma attached to using enemas at night. People can't do it themselves, they can't have help sometimes. But this is very, very underused, and I think we should promote more use of rectal suppository enemas in our practice. Next line of drugs is budesonide. Prednisolone has been the backbone of inducing remission. Budesonide MMX is a new drug which has come out in the market, is being promoted to be effective in people with ulcerative colitis. Then we move the next step, we go on to immunomodulators. Azathioprine is by far the most commonly used. Then there's biologicals, which are new molecules, expensive, difficult to get procured in India and not for everyone because the cost becomes too high. Then there are the new class of drugs which are gaining popularity, JAK2 inhibitors, and I'll talk about this a bit later in the talk. So whenever we say patient of UC, the first thing we classify them based on the symptoms and the endoscopic features into mild to moderate disease. Mild disease, if it just extends to the lower rectum, we just treat them by local therapy. Topical mesalamine with suppositories, foam enemas, or liquid enemas is actually good enough. Liquid enemas tend to go up much more in the proximal splenic flexure, so the disease is more than just sigmoid, and enemas is probably better. Suppositories is good to give treatment to only last 10 centimeters or so of the gum. If the extensive colitis, we tend to add in oral tablets as well. Now, one of the problems which we face is, which I've seen in my practice, that a lot of patients who have started, they've started in a smaller dose. They can't believe that 4.8 gram per day is a dose. They think it's too high. They do not take it enough. So I think we have to make sure they understand the fact that the higher dose is more effective than lower dose, and if they combine it topical mesalamine, which is usually in enema form, then they actually feel a lot more better, a lot more quicker. The symptoms of tennis spells, the bleeding improves a lot more quicker if you use rectal preparation along with oral preparation. For mild to moderate disease who have actually failed mesalamine therapy, we tend to add oral corticosteroids. Visolone has been the background and backbone forever, so we start them on usually the 40 milligram dose and reduce over the period of the next few weeks. And then we either leave them on a, let's say, a small maintenance dose, or we taper it or stop it completely. So it depends on how the patient does. Budesonide MMX, 9 to 10 weeks has been promoted recently, but in my opinion, the cost is a bit too much. A lot of patients who are on MMX go back to taking Visolone, and people who have taken Visolone in the past, they say, why are you giving medicine that costs 20 times more than what my Visolone does? So people who have this chronic illness are on medication for a long time, and the cost of these medications is actually becomes an important part in treating these patients. Azathioprine, anyone who is, in my practice, if you've had 2 doses of Visolone in a calendar year, I put in azathioprine. I start with a small dose of 50 and then build it up. If they tolerate, even build up to 2.5 milligram per kg body weight. They have to be monitored regularly by having regular CBCs, and they have to be told that they should not stop it without medical attention. They should regularly have their, let's say, monitored, because the scan called neutropenia result in more infections. 5-ASA remains at the background. It's always there. I never stop it, at least for a few years. But that's something which I would tell the patient when they first come in. They expect you to give treatment for a few weeks, and then they think they will stop it, but that's not true. There's a disease condition, acute severe ulcerative colitis. I'm not going to talk about it because it usually requires an inpatient stay and can be quite complex treatment, and patients are usually very sick. What if these things don't work? Then you have to take it a step further. And biological therapy is what we can do. Infliximab has been the backbone for a long time, and adalimumab is there. But each of these injections are expensive, and often our patients are unable to afford it and take it on for longer. So JAK2 inhibitors is a new class of drugs which have actually shown a lot of promise. And it's something which can be given orally. It's not very expensive. And initially it was used as in patients who actually had failure of infliximab or other biological therapies. There has been, some data coming out from Indian studies which have shown that's effective as a first-line agent as well. And so using steroids, you can use tofacitinib. And I think as time goes on, we'll get to know more about it. As with any of these immune suppression drugs, one big problem is of infections, and TB is something which we all are worried about, especially in endemic country like India. So we tend to screen for TB before starting tofacitinib, and we start with 10 milligrams and then maintain at 5. Few patients have used it on with very good relief, and I think it's a great drug going ahead in the future. Surgical treatment is something we always, gets pushed in the background. But I think in the Indian context or in anywhere, surgery should be something we should consider. So I've had some of my patients who have been poor, and we're talking to them, putting on biologicals, and then they hear the cost of maybe 3 or 4 lakhs in a year, and that much money you can get a surgery done and get cured for a life. So I think even the biological therapy in acute severe ulcerative colitis, I don't know how many people in Indian context survive without losing the colon for more than a couple of years. So I think thinking of surgery is a good option. The big challenge we face is who to send to. So I think surgeons should, have a kind of a network and develop expertise in doing the pulse surgery. One One of the problems with pouch surgery is pouchitis or pouch failure, which is quite common and can be quite tricky to treat. But that's again something, it may be a better trade-off than being on toxic drugs the rest of their lives. If you worked in the West, one of the big time-taking thing was this regular colonoscopies in patients to screen for colon cancer, because they have increased risk depending on the extent of the colitis and the active disease. Is that applicable in a country like India, where we have low incidence of colorectal cancer in the background, is up for debate. But this is a study published from AIMS, which they clearly showed that they looked at 31,000 patients. This is all throughout Asia, but there was a subset of around 1,000 of patients from India as well. And they clearly have showed that the risk of colorectal cancer in general population may be low, but in people with inflammatory bowel disease, the risk of cancer does remain. And we should be thinking of screening these patients in due course. So the prevalence was, the longer you had the colon cancer, colitis, the more effective the colitis was, more extensive it was, more risk of cancer was there. One of the studies which are researching, I found that what causes people to have flares, and this is studied from Chandigarh. I think one of the authors is sitting in the audience. So what I took from this study was that there was a lot of antibiotic usage, and antibiotic usage associated with increased flares. Lack of better therapy was again another point, and the most important point in terms of stopping therapy is actually cost. 5 basic commas are not cheap, and if you think of biological, they can make things a lot more expensive. The use of other medicines such as homeopathic, Ayurvedic, other complementary medicines also is very common in this group, because they seem to think that the medicine doesn't help and something else might help, and people will switch from one to the other, though some people will take alternative therapy along with the medical therapy as well. Use of non-steroidals is again a major reason for flare. Another thing which I wanted to point out was people who use azathioprine. They are the ones who actually manage to have less relapses. Because I think that's a drug which is very, very underused in India. And I've seen patients on prednisolone 20 milligrams for 3 months, 6 months, 7 months, and they're steroid dependent. That's the kind of group we have to actually put them on azathioprine. It's a cheap drug, not expensive. The only issue I tell everyone that we have to be aware of immune suppression, especially leukopenia, which can happen quite often and can come and present without any, let's say, symptoms. Another study in Indian context, no one had ever done this before. This is the cost of illness in India. Interestingly, it's around people who are in remission, it's around 43,000 per year, and people who have flares with 53,000 per year. So this kind of data was not available in India, but now we are finally getting papers which are coming out. And this clearly shows that the interest in IBD in India is increasing, and I'm sure it gets to be a major point as we go on in the future. So what is the bigger issues we have in ulcerative colitis? One thing which we see that a lot of patients present to us late. A study from Asian Institute of Gastroenterology showed that there's average 2-year delay from symptoms down to diagnosis. But that is too long a time for patients to remain without proper care. The presence of TB and infective colitis tends to muddy the water. So we see a lot of patients who have had bouts of diarrhea, they have taken multiple courses of antibiotics, and then they present and we do a quick sigmoidoscopy and find that they've got ulcerative colitis. Lack of access to healthcare, getting sigmoidoscopy done, colonoscopy done requires special skills, special centers, and not widely available. Calprotectin is something which a lot of data, a lot of, let's say, people talk about, but I think in my opinion, India is shortage because calprotectin will also pick up all the patients who have got infective colitis with mucosal damage. And it doesn't clear, let's say, with the clear-cut diagnosis, not made very easily on that. Embarrassment is one reason I see a lot of women who don't come to see doctors. And I've come across patients who have had diarrhea for 3 years, 2 years with bleeding, and when they become anemic or fallen ill, they have come to the hospital. And when you ask them why did you seek help, they say they're embarrassed to go to a doctor. So I think that barrier, that, especially a lot of doctors being male, people don't come and see us. So I think having a junior colleague who's a female who can talk, or a nurse can get an idea of, you get a lot of answers from them. So we see a lot of patients who will not talk about their bowel health because they're so embarrassed. But I think that's a barrier which we have in healthcare. We need to break that down. Maybe using a nurse or maybe using a junior colleague may be more useful. So what can we do to make things better? First of all, I think we need to understand that ulcerative colitis and Crohn's disease will become a major factor as we go on in the next decade or so. We have to get more understanding about the mechanism why we see it in India a lot often. We have to get the awareness out of the people, among not only the general public who need to understand when to seek help, but also among the general practitioners. They need to be able to refer to a doctor for or defer to gastroenterologist for further treatment and help. So we have to get some referral pathways going. So I think people like Servit, who you go and talk to in community, you can actually have a pathway where you can have a kind of patients coming through if they have IBD, so you can make the, general public and general doctors aware that there's something known as colitis and they should seek help. Especially in Punjab where colitis is a lot more common than anywhere else in the country. We have to come up with local guidelines. We have to come with the Indian guidelines. The last time ISG had a guideline was in 2012, which is 23 years ago. Now the entire paradigm of treatment has changed. We should try and get some local registries so we have some data about the prevalence incidence, see how many people have what extent of disease. And if possible, we can make a center of excellence, which usually should be done through the government sector, so it makes it a lot more easier for people to access it. And biological is something which is being more and more used, but the cost is extremely prohibitive. If I tell you I have to spend 20,000 rupees injection every 2 weeks, you will think twice before going for the treatment. So I think we have to try and subsidize it, and we have to get some insurance coverage. Insurance is a major problem. And I think I'll end here. Thank you.
Thank you, sir, for your words of wisdom. Now I request Dr. Pola Singh Sidhu to kindly come forward and honor our speaker.
Some surgeons in the audience also. Just share with you one case. More than 25 years ago, a BDS student from Dental College Patiala was brought to us in emergency. And you can imagine what investigation we had at that time. Clinically, we thought peritonitis, and with all the history, it's possibly colitis and problem we opened up. Hole on the colon, quite angry, had to perforate at some places. I did total colectomy, and the rectum was cleared, iliorectal anastomosis, put in the drain. The anastomosis leaked as expected. It was inexperienced at that time. I should have done the colostomy. Anastomosis leaked. She went into septicemia and had seizures. We sent her for CT, and she had some infarct in the brain. The young girl came back quickly. I took her to the OT, did ileostomy. She recovered, then referred her to Delhi. Dr. Adarsh Chaudhary did the pouch surgery, and after a few months she recovered, completed her BDS, and is now well-established dental surgeon in California. Isn't it interesting?
Thank you, sir. As ulcerative colitis is on an emerging trend, and so are its treatment modalities, we have amongst us the next speaker, Dr. Naveen Kumar, to highlight the UK perspective of ulcerative colitis. The stage is all yours, sir.
Good morning, everybody. I would like to take this opportunity to thank the Service team for giving me this immense opportunity. I'm truly honored. I would also like to congratulate them for 10 years of this GI Rendezvous. It's an amazing achievement. Can you hear me now?
Yeah.
Hi, good morning. Can you hear me? Yes. Hi. Good morning, everybody. I would like to thank Service team for giving me this immense opportunity, and I'm truly honored. And I would also like to congratulate them for 10 years of this GI Rendezvous program, which I consider is immense success. And I wish them more of this in decades to come. So the topic today is ulcerative colitis UK perspective. Technically, I can stop here and go because Dr. Abhishek has said everything that can be said about ulcerative colitis. But that would not be happy with Dr. Gurbala Singh because he's brought me here to give a UK perspective. So I'll go through my slides. Please stop me anytime you want, and questions I'm quite happy to take. So what is ulcerative colitis? Ulcerative colitis ulcerative colitis is inflammation of rectum and colon of unknown etiology. Starts with rectum, progresses proximal towards cecum. We don't know the etiology. Environmental factors are being put forward, but we don't know what environmental factors. But there is some suggestion that with the invention of refrigeration, the incidence of colitis has mirrored the use of refrigeration. So if you see the graph of refrigeration going like that, the ulcerative colitis graph parallels that. So I'm not saying that refrigeration is bad, but that's the data. How do we diagnose? We generally start with blood test. Fecal calprotectin may not be useful in the Indian context because of other infections. Lower GI endoscopy. That's the one thing that will give you diagnosis. If you expect a histopathologist, radiologist, or someone else will give you a diagnosis, it's not going to happen. It's the endoscopist. So you've got to train your endoscopist to diagnose ulcerative colitis and rule out other causes. What do we do at endoscopy? We do, one, confirm that it is ulcerative colitis, to determine the extent, whether it's limited to the rectum, in which case we call it proctitis, up to 20 centimeters from anal verge, or left side up to splenic flexure, and extensive beyond splenic flexure. And we also determine the severity. We use various scores like Mayo score or ulcerative colitis endoscopic index severity score. The reason for doing those things is to determine what kind of treatment you give. Exactly like what Dr. Abhishek said, it takes 2 years to diagnosis. The situation was same in UK as well. It used to take up to 4 years to diagnosis, but that has changed rapidly. Now it gets diagnosed in as little as 2 weeks. This is because of the government's policy of using a 2-week wait referral scheme, where anyone with bleeding from rectum is suspected to have cancer and they're referred, and everything gets fast-tracked from there, including the sigmoidoscopy or colonoscopy as the issue may be. what are the goals of treatment? There are two perspectives. One is the patient perspective. What does the patient want? Well, he wants, or she wants, they want to be symptom-free, drug-free, and lead a near normal or normal quality of life. What does the physician want? The physician wants the inflammation to have completely healed, and avoidance of any complication. Why do we need complete healing? Histological remission, as we call it. That reduces the future risk of flare-ups, steroid use, which has its own complications, risk of perforation, risk of acute flare-ups, risk of dysplasia, risk of colectomy, and reduced quality of life. So the current trend is to achieve the histological remission. How do we do this? This is the basic structure I've used for my talk, how I do it. Like I said, during the endoscopy, you determine whether it's mild, moderate, or severe, and then tailor your treatment accordingly. This is the foundation for my talk. In the mild, you see, like Dr. Abhishek said, 5 ASAs are used, 5 mesalazine, oxalazine, sulfasalazine. They're fantastic drugs, they are standard, they work well. Majority of the patients get better in mild ulcerative colitis. The only caveat is that it can have some nephrotoxicity, about 40%, 1 in 4,000 in about 2 years' time, which is reversible, by the way. You stop the drug, nephrotoxicity gets better. Left-sided colitis, we use again oral 5-ASA. You can use enema, like Dr. Abhishek said. Same thing in UK as well. For proctitis, you prefer using suppositories. It's not such a big taboo down there. Patients are happy to use. They don't want to take tablet orally. Sometimes it's ineffective as well, because the tablet has to travel all the way from your mouth to the rectum area where it needs to be effective. It doesn't get absorbed in large quantities to work through the bloodstream. In moderate, you see 5-ASA is still major treatment, major modality of treatment. You can use what you want depending on the site, whether it's pancolitis, in which case my preferred choice would be a pentasa. If it's left-sided colitis, I would use Asacol, because the release system is better on the left side. You can also have the 5-ASA in a multi-matrix formulation, which works much better for the left-sided rather than for the right-sided. When the 5-ASA fails, the next go-to treatment for me is budesonide, again in a multi-matrix format, 9 milligrams per day, up to 3 months. But I should be thinking of what am I going to do next after the steroid is stopped, in which case you come to the thiopurines, azathioprine, 6-MP. Those are my standard drugs. I would do the usual things, check for TB, HIV, hepatitis B, C, CMV, chickenpox, immunity. If they're not immune, then consider immunizing them before I start them on azathioprine or 6-MP. The caveat is that these can be quite toxic drugs. They can have an impact on your bone marrow. So you need to check for TBMT. And then once you start them at some stage during the treatment, maybe 6 months or a year down the line, you would also want to make sure that their metabolite levels are checked, so they're not developing toxicity. They need regular, in the first few weeks, you would do every week blood test, full blood count, urea electrolyte, CRP, and liver function test. After 3 months, you would do every 2 weeks. After further 3 months, you would do once every month. And in about 9 months' time, you could change if they're stable and no complications, no side effects. You would do once every 3 monthly blood tests. What happens when the thiopurines fail? We have biologics. Act 1 and Act 2 studies gave a fantastic results. Infliximab, which kind of revolutionized the treatment of ulcerative colitis. I'll mention a little bit more about the True Love and Wit study a little later when I come to acute severe ulcerative colitis. But infliximab has done a fantastic job. It reduced the amount of colectomies and also hospitalization and steroid use. But they do fail. Unfortunately, 50% of these drugs lose either effect or about 20% of them are initial non-responders, in which case you need to be thinking of next set of drugs. What are the next set of drugs? These are the small molecules. These are the new kids in the block, the JAK inhibitors, the S1P receptor modulators, the tofacitinibs and ursinamides. I'll come to that in a little bit more later. The severe ulcerative colitis or active severe ulcerative colitis is a life-threatening condition. In 1950s, when Truelow and Witt were publishing their first set of data, that was the first randomized controlled trial in this specialty, in this condition. The number of patient use was just 237. At that time, the mortality rate was 50%. 50% of patients who came in with acute severe ulcerative colitis died. We're not talking about colectomies, but mortality. And that today is less than 1%. So it has been a truly marvelous journey with all the new medications since in the last 70 years. In acute severe ulcerative colitis, I've got a couple of flow charts later on, which is what we generally follow. The first modality is to admit the patient, IV steroids, day 1, day 2, and day 3. Day 3, if they're not responding, then you start thinking about the next set, in which case either it's cyclosporin or infliximab. They both work fantastically well. Depends on what their previous journey has been in terms of drugs. If they've used azathioprine in the past, you would go to infliximab. If they've used infliximab in the past, you would go to cyclosporin. They reduce the requirement of colectomy by a good 50%, which is fantastic. But by the time you reach day 6, if they're not responding, you start involving the surgeons. Not because they need surgery immediately, but you want to be talking to the patient, getting the thought of colectomy and having a stoma bag into their head, so they can start planning and they can come to terms with the idea that they will be having a surgery and a stoma bag. One thing that patients with ulcerative colitis dread is having a stoma bag. They don't like it. It restricts their lifestyle, it restricts their quality of life, all sorts of embarrassments, and their diet as well. So what do we do if by day 7, by day 8, they're not responding to infliximab or cyclosporin? Then you consider giving them rescue therapy. Tacrolimus has also been tried, but I've had no experience, so I'm not going to talk about it. Vedolizumab is also another drug that has been that's been used in patients who do not respond to cyclosporin or infliximab. Vedolizumab has been used, but this is with the word of caution. The more you bash these patients with drugs, their surgical outcome is poor. So you've got to start making plans for surgery sooner than later before you marinate them in too many drugs. That's the flow chart I was telling you about. Day 0, you do all the blood tests and then stool sample tests, flexible sigmoidoscopy, then start them on a high cortisone or prednisolone depending on your choice. You also start them on low molecular heparin to prevent them getting DVTs, because that's a very high risk of getting DVTs and PEs in this group of patients. CMV, the sigmoidoscopy also tells you if the features are typical of ulcerative colitis or if there is a C. diff, and you also take some biopsies to make sure they don't have CMV, because the treatment modalities are completely different. This is day 3, you're not responding, you start thinking about other modalities, like I mentioned, cyclosporin, infliximab. Day 6, they're still unwell, then 3rd line medication, and surgical involvement. And by day 13 or 15, they're not responded, then they should be having surgery. What kind of surgery? Surgeons are best deciding what to do, but in most cases, if you're doing an emergency surgery, it should be colectomy with tracheostomy, leaving the stump back to reconnect it at a later stage. But that again depends on who you talk to. If you talk to a 70-year-old man or a lady, they don't want to have anything done. Just leave me a stoma, I don't want to be bothered anymore. You talk to a 20-year-old, they don't want a stoma. So eventually you need to reverse the stoma restorative surgery. So you've got to be planning that. Surgeons are best, and like Abhishek said, you need to find the right surgeons. There's a variety of surgeries that can be done, like you mentioned. Pouchitis, Dr. Abhishek mentioned briefly about pouchitis. This is the complication. Up to 50% of patients get pouchitis in 1 year, in the first year. The treatment depends on what kind of severity it is. Generally, 5-ASA will do if it's due to ulcerative colitis, but there are patients who don't respond to their antibiotics, repeated courses of antibiotics, probiotics. All these work, but not as good as steroids. You've got to keep that in mind. Most important thing is to make sure it's not a surgical complication that you're dealing with. Make sure they don't have sepsis, they don't have ischemia, they don't have a very long rectal stump, in which case it acts like a flap. So in which case you need to use catheter to drain them rather than bash them with drugs. If nothing works, there is a possibility that you could use immunosuppressive medications like azathioprine. And if even that doesn't work, biologics will do the job. One thing to make sure is that occasionally people confuse ulcerative colitis with Crohn's and they end up with a pouch surgery, and then after they've had the pouch surgery you realize that this actually is Crohn's disease. So in that case, you need to treat them like Crohn's disease. Pregnancy. Ulcerative colitis doesn't have any age predilection, so young as well as old get affected by it. Young patients, especially women, it can be quite a challenge. They either become pregnant unplanned, or they would want to have kids, in which case it's a planned pregnancy. So you got to start thinking about what to do with them and what to do with their drugs, because some of this can be quite toxic to the babies. The current suggestion is that if it's an unplanned pregnancy, then continue with the medication, whatever they're taking, as long as their colitis is, I'll just take 2 more minutes, as long as their colitis is well controlled, because the biggest risk to the baby is not the drugs, but it's the colitis that causes abortions and poor outcomes. But if it's a planned pregnancy, then make sure they're not taking any toxic drugs, provided their colitis can be controlled without that. And then plan, most of these drugs have a washout period, so give them adequate time, fill them up with folic acid, and top up their hemoglobin, make sure their hemoglobin is normal, and then you could allow them to become pregnant. What do we do? Delivery modes is normal delivery unless they have a perineal disease, in which case you should start thinking about cesarean section. Breastfeeding is okay. Even the biologics don't get transferred in breast milk in great quantities, about 2%, which the baby's gut will neutralize. The enzymes in the baby's intestine will neutralize them, so you don't need to worry about it. Avoid live vaccines if the mother is being given immunosuppressive therapies or biologics. I think I will stop here. What next? Biologics, combination of biologics available as generic formulation here, and you could get a year's worth of TOFA for as little as 8,000 rupees. It's become cheap.
Thank you, Dr. Kumar, for highlighting the different perspective of ulcerative colitis than that we see here. I request Dr. H.P.S. Miglani, President, Indian Association of Pediatric Surgery, to kindly come forward and present a token of appreciation to our speaker. We also request all the speakers to kindly stick to the time limit, as we are already running short of time. A disease donor's in India. We welcome you, sir.
The food that Amritsar offers. So it's always a pleasure to be here. So while the slides are getting ready, I just want to talk a little bit about or give a background of the presentation that we had. So we talked about disease donation. So when somebody say from Punjab wants a transplant, somebody has a loved one who has got kidney failure or liver failure, then what is the thing that comes to your mind? We find somebody from the family who's willing to donate either kidney or part of their liver, make sure they're healthy, and then we ask them the difficult question of actually going through an operation which has a risk to their life to be able to save somebody else. That is something that we have normalized, but I would like to talk to you about another way, if it's at all possible. That is the way of deceased organ donation. While listening to so many of these eminent speakers today, one thing that comes to my mind is that there's such a big gap between what we hear about what India should be and what India is actually, isn't it? We always think about India as not donating organs, being behind in technology, just being doctors and not innovators. And today, hopefully in the next 15 minutes, I can change that to some extent. Do we have slides? Not yet. Can you just play from whatever and we'll miss the video otherwise? No, चला दीजिए, video नहीं आ रहा है उसमें। कोई बात नहीं। So it looks like we'll miss a few videos, which means I'll get out of here a little earlier. So that's good news for all of you.
Sonal, while the slides are being sorted out, they have already sorted.
He doesn't want you to ask any questions.
I
Yeah. Thank you so much for not letting Dr. Ravindra ask us questions. So these are my current appointments. I do not have any conflicting interests in this. So I'm going to talk a little bit about background need, why we talk about disease donation. I mentioned that briefly in my introduction. There's some of the legal aspects, challenges, the good and the bad. And more importantly, I'd like to present our data over the last 15 years of running a DDLD program in India. So we talked today about unity. We talked about why it's important to be together, and I cannot think of a better symbol of unity than the Golden Temple. This is what draws so many of us here, year after year. And of course, when we talk about the many Indias, the Indias that you hear about and the India that you think about, one of the common things that I heard, especially when I was coming back from Canada, was that Indians don't have the cultural appetite for organ donation. And then I really thought about this to a large extent. I mean, why is it something in our history or culture that says that we cannot donate organs? And then when I look back, we already know that there are stories in our mythology of, the transplant of an elephant's head to a baby boy who was accidentally decapitated by his father, who became one of our most popular gods. But of course, when you look further, there is also, sort of deeper mythology. You have the mythology of people sacrificing their whole bodies. This is Rishi Dadichi. This is a postage stamp issued in his honor, who gave up his entire body. He voluntarily killed himself so that his bones could be used to fashion a weapon that the Devas could use to destroy the Asuras. So there is a strong theme of organ donation in our mythology as well. This also compares, of course, very well with the Western themes of organ donation. You have the chimera on the right side, which has the attributes of the lion, the goat, the snake, etc., which is the best of all different bodies to make a new body, which is actually basically going in well with the theme of transplantation. When we talk about the milestones of transplantation, it's a very, very young specialty. It's not more than 70 years old. The first transplant that was done between identical twins in 1954 in the US. The first liver transplant was done in 1967 by Dr. Thomas Tazer et al. It wasn't until the mid-1980s till we actually got good immunosuppression. I heard some of the drugs, cyclosporin, that you heard about in the previous talk. This was the drug that revolutionized the use of in transplantation to prevent anti-rejection. And since then, transplantation has taken off with more than 1 billion transplants being performed annually across the world. When we look at India, the first transplant in India was attempted in 1965 from a deceased donor, as it happens. It did not succeed, but the first successful transplant in India was in 1971 in CNC Vellore, which was a living donor transplant. Deceased donor transplants actually started in India after 1994, when the law that actually enshrined testing brainstem death was passed by our parliament. Since that time, the first liver transplant was done in 1998, and it has been a steady improvement ever since. Where are we with our numbers? When we look at the numbers, we are not even scratching the surface of what we need. Our renal failure rates are 226 per million population. Our renal transplant rates are only 3.25 per million population. So when we talk about liver, although I'm a liver guy, kidney is actually the biggest need. 90% of the people with renal failure in India die before they can get dialysis. We are actually not even reaching a percentage of what we really need to do. When we talk about India, we think that about 50,000 people need a liver transplant. Only approximately 4,000 get one. And out of this, 25% are not. So only 3,000 out of 50,000 actually reach a liver transplant. Liver disease is a public health. We know that about 112 million people across the world
And the only side effect was dark stools, which we should explain to the patient. Now there are two therapeutic approaches. First is empirical, which is recommended by most guidelines. Second is tailored approach, which depends upon the resistance patterns. We can test PCR-based testing, which is genotypic testing, and second is phenotypic testing, which is culture-based testing. Now, if we use bismuth-based quadruple therapies, then there is no difference between both the approaches, and even using it without doing an antibiotic susceptibility testing, eradication rates were more than 90%. Another important question which is asked is that how to use bismuth quadruple therapy. We can use it in various forms like classical bismuth quadruple therapy or modified bismuth quadruple therapy. The therapy which I personally use is adding bismuth to the standard triple therapy, and it has shown very good eradication rates. When the study in CGS published in 2020 has shown eradication rate of more than 94%, and even in resistant strains we can get a eradication rate of around 77%, which are acceptable in view of high dual resistance in this area. Now, there is no role of using concomitant therapy and sequential therapies in any of the guidelines because they are not superior to bismuth quadruple therapy and they don't work in dual resistance. So we should not use them now, and the resistance, you can see the eradication rate of less than 50% when we use concomitant or sequential therapies in eradication. Again, the role of vonoprazan, these landmark trials have shown that adding vonoprazan to the triple therapy can eradicate H. pylori even in resistant strains. This is important because acid inhibition can bring H. pylori to the replicative phase, which increase the efficacy of antibiotics like amoxicillin and clarithromycin. And AGA recently approved its use for HP eradication. This is the only indication which they have approved vonoprazan, because we should use vonoprazan only for limited duration of time, like 14 days for H. pylori. Now, another brief role of probiotics. Recent meta-analysis from 91 RCTs have shown that adding probiotics to the H. pylori eradication can decrease the side effect profile as well as increase the tolerance, and it also can increase the eradication rates. And when they did a systematic review of the type of regimen, Bifidobacterium longum was the most effective. However, we are not still sure what is the duration, what should be the dose, and these are all low quality data to recommend probiotics in every regimen. So the evidence-based approach is still empirical. We should use triple therapy only when local resistance patterns are available, and when used, we should use vonoprazan-based triple therapies if we know that the patient is sensitive to clarithromycin, and if the patient is treatment naive, we should use first line as a bismuth quadruple therapy. I've told you different forms of bismuth quadruple therapy as per the tolerance of the patient. If patient fails, then we can use levofloxacin-based quadruple therapies. Adding bismuth to the levofloxacin-based quadruple therapy also works very well in this area. And again, if after 2 failures, if we have antibiotic susceptibility testing, we should do that. If it is not available, we can use PCAB or PPI-based rifabutin-based therapies, which are again very effective. However, there is a concern for using rifabutin due to the it is used for anti-tubercular therapy and the risk of myelotoxicity, but the recommended doses has not shown to cause any side effect among the regimens. The second is if the patient is already exposed to the treatment, whether he or she is exposed to triple therapy or whether he or she is exposed to bismuth quadruple therapy. If patient was exposed to triple therapy, we can use bismuth quadruple therapy. If patient was exposed to bismuth quadruple therapy, we can directly go to levofloxacin-based quadruple therapy, or we can use directly rifabutin-based therapies, but we should always avoid using clarithromycin and levofloxacin again if patient has already taken it previously. And we can also use classical form of bismuth quadruple therapy if the previous therapy was concomitant therapy or sequential therapy. And the role of probiotics is still not clear, but they have shown to increase the tolerance of therapy as well as decrease the adverse effect profile. And there is still no role of using high dose amoxicillin therapies in India because of the high resistance rates seen among amoxicillin also, which is very less in the rest of the world. And always try to confirm eradication. We should treat it as a continuous episode, test, treat and confirm. This is important to tell us whether our therapies are working, because we don't have any AST-based methods to detect resistance, and only eradication rates will tell that which therapies are working better or not. And also it has better long-term outcomes in terms of peptic ulcer disease, in terms of gastric cancer risk. And the take-home message I want to tell is that H. pylori is a pathogenic organism. It is the most prevalent chronic bacterial infection. We should test only when indicated, and we want to treat. Otherwise, we should not test it for any condition, GI condition. Choose diagnostic test as per clinical scenario. If patient is exposed to PPI, bismuth or antibiotics, always repeat the test later on with non-invasive methods, ideally off therapy, or if PCR-based methods are available, we should use that method in case of this scenario. Bismuth quadruple therapy should be the first-line therapy if we don't have any antibiotic susceptibility testing available. Monitoring local resistance pattern and eradication rates on regular basis is very crucial. Potent acid suppression is very important for a better eradication rates. Always use second generation PPI or PCAPs for better eradication rates. Like if we're using PPI, use esomeprazole, rabeprazole. If we're using PCAPs, use vonoprazole. And need to develop economical antibiotic susceptibility testing methods in India. We still need more data on this. And don't treat this infection in very old patients, in patients who have advanced stage of gastric cancer. We should always take a shared decision making, because of the risk of giving multiple antibiotics will further increase the resistance. Thank you.
Thank you, sir, for enlightening us. May I kindly invite Dr. Pratap Singh Malhotra to the stage to present a token of appreciation to our speaker. Now the house is open for discussion for the above sessions. Any questions are welcome from the audience.
The best way to predict the future is to invent it. So talking about future, let's call upon stage Dr. Shailesh Puntambekar, a pioneer to do the world's first uterine transplant, to deliver a keynote lecture on robotics in GI surgery. Welcome, sir. Let's embrace the future with your thoughts.
Good morning, everybody. At the outset, let me thank Dr. Ravindra Malhotra for inviting me to this wonderful conference. And in the next 30 minutes or so, I will take you through this wonderful journey of robotic surgery. So we know that robotics has been applied in a minimal access surgery, and this uses for dexterity, then of course super visualization, and to perform complex surgery. There are various types of robots which are available, right from Da Vinci, Zayat system, ASOP system, CMR, and of course now there are two more, Yoga Boss and Mantra. So this is the history of robot. 1985, the first CT-guided brain biopsy was done, and then in 2000, the first surgical robot came in, which was the Da Vinci surgical robot system.
This was based on the ASOP system that was done in Germany, and this company was purchased by Da Vinci and then the robot developed. This is the robot which was there. It was an automated endoscopic system just to hold the camera and go in, and just had one robotic arm. Now with the Da Vinci series, we have multiples of robots which are available. You can see the latest series which is X. The next robot which came into the picture was a CMR robot, and you can see it started as a separate arms. And we were the first to have the clinical installation of this robot in 2019 and of course August 2019. So this is the CMR robot, this is the Swiss system, and right now all kinds of robotic surgery are done right from the top to bottom because of course dexterity, then realistic 3D vision, precision and limited external trauma. Why is it so? It is because of greater maneuverability, you can do it better. Of course you can move about 270 degrees as compared to rest of the thing. And of course, as we see, accuracy, predictability and duplicability, which remain the key steps in surgery. Anybody should be able to perform the same level of surgery. That is the most important thing, and this is where the robot helps you to fill up the gap between having the skills and not having one. It is very difficult to adopt to straight stick surgeries after the age of 45. Robotic surgery, of course, fills up the gap, and you can directly graduate from open surgery to robotic surgery. Now, this is just one history which I will tell you what are the various kinds of system which was used. Advantage of robo, you can see the precision with which the robotic surgery is done. We can see the grave skin completely being peeled off without damaging the grave, and this is the kind of precision that exists in the robotic system. So this is how you can do all these completely, nicely, precisely and clearly sitting on the system. Various advantage, you can see I do both kinds of surgery. Straight trick surgery is very easy to do for me, but it is very difficult to teach each and every person, and while robotics it becomes easy. The biggest advantage is to the surgeon, his life as a surgeon increases because you're sitting on the console, you're not actually having any kind of occupational hazards, and this is one of the things, no risk of any kind of transmission, and this is the area. I probably have the honor of operating on all the three systems. We also are operating on Mantra, Da Vinci system and CMR robotic system. And this is our experience. We first started doing, we were the first to do the robotic esophageectomy in the country. This is on one side you can see the CMR robot which we are using regularly, and the other side you can see the Da Vinci system which we started using from 2009. If you look at the intuitive movements, you can see there is no difference in the movements. You can see that the robotic system which you can see on the other side, that is the Da Vinci system which is there, which you can see there, and the other one on this side is the CMR. You can see the precision with which the esophagus is being dissected out completely over there, and this is what is the advantage. You can see that we are going between the aorta over here, and of course you can see the azygous vein. We can preserve the azygous vein because taking out the azygous vein was just for oncological safety, oncological approach, and not for oncological safety. Now the stomach tube remains in position. What I want you to focus is that both the robots have the same intuitive movements, and when you have a very, very limited space, you can see you can use various instruments, and this is very helpful, especially in the thoracic area. So this is a kind of a robotic system. First robotic publication from India was in 2010 by me. We started doing it on Da Vinci since 2009, and now since more than 16 years we are doing the same. Can we do the same procedures with low anterior resection? You can see again the CMR robot on one side. You can see the inferior mesenteric artery being taken. Once you take the inferior, and on the other side you can see the Da Vinci system. This is called as the shears. This is a shear which you can see here, and the other side, the blue one, is the CMR system, 2 individual arms. This is done with the XI. You can see the inferior mesenteric artery completely denuded. The same steps, nothing changes, the same steps repeated on both the sides. You can see the inferior mesenteric artery clip. Of course, now with this excise system, you also have a clip applicator which is available. And then once you do that, then of course, the biggest advantage is, especially in our very high BMI patients, and not only high BMI patients, but with patients with narrow pelvis, when you want to go into the presacral area, you can see the preservation of the nerves, and of course, everything becomes much more easy. You are sitting on the console, same repetition, fat belongs to the rectum, is the dictum, this is the TME plane of biliates, and you can see how nicely we can go in this plane. The only difference is we are not using any laparoscopic energy sources, just the monopolar and bipolar, again going to the basics, and you can see the entire low anterior resection being done. So look at this, though this is an edited film, hardly a blood loss because you are cutting millimeter by millimeter. We can of course do the same surgery with laparoscopy, but with robot, of course the comfort to the surgeon is much better. You can see that, and when you go anteriorly, this is between the prostate, you can see that the same kind of precision can be used. This is between the prostate and the seminal vesicles, and you can see how nicely you can do the dissection very clearly. This is especially helpful. Nowadays we get patients between 40 to 45 BMI, and this is extremely helpful to do the robotic surgery. Can we do right hemicolectomy? Of course, any procedure that we used to do with laparoscopy, we can do this. I am purposely kept on both the sides the same thing so that you don't get, it is not the kind of robot that you are using, it is the intuitive movements of the hands, it is the ease of doing the surgery, it is the exact movements, because this is a master and slave relationship. The robot will act as well as the master operates. So unless you know the anatomy and unless you know what exactly you are doing, you will not be able to do this. So this is how you can go ahead and do this completely. You can see the ileocolic vessel. This is the Todd's fascia. You can see the Todd's fascia being completely clear. You can see the duodenum on the other side. That's the duodenum. This is the right plane that we normally go into. And once we go there, then this is the area that we like to go and do this entire dissection. Always medial to lateral dissection. You can see the dissection being done the same way that you would like to do, and not touching the tumor, but taking the vessels first. And as you take the vessels, again you can see the Todd's fascia, the vessels being taken, and this is a complete right hemicolectomy which can be easily done with both kind of robots. You can see the comparison. This, can you do a radical colate? This won our first award at the SAGES conference way back in 2014. This you can check on the net. We did the radical complete cholecystectomy with complete clearance with this Da Vinci robot, and you will see how it is being cleared. The same kind of thing, that is the inferior vena cava. The basic area is to take out all the nodes, and as we go along, you can see that that is the portal vein, that's the pancreas coming up, and we keep on taking out all the nodes slowly. This is the hepatoduodenal ligament. You can see all the nodes slowly and steadily being taken out. This precision, continuous steady camera movement, and this is what helps. You can see the common hepatic artery dividing into the left and right artery, the gastroduodenal artery, and all the nodes in the hepatoduodenal ligament being completely cleared, which actually forms the basis of doing a radical cholecystectomy. And look at that, though if it is an edited film, the important thing is that there is hardly any blood loss because the vision is very good. Millimeter by millimeter cutting, you can see the hepatic artery pulsating. Take out all the nodes along the hepatic artery, and as you take out all the nodes along the hepatic artery, you can see the artery now dividing the gastroduodenal lower down, and below now you will see the portal vein which is coming up. That's the portal vein which is coming up, and all the nodes along the anterior and the lateral surface of the portal vein are being slowly, steadily but surely being taken out. And this is how you can do the complete, not only that, so this is how you see you have skeletonized. This is the same way that you would do in open surgery. You try and possibly take out end block dissection of the nodes, but you cannot take out the nodes along the IVC end block. They are different. So you see each and every step. Those are the lymphatics. Those are small lymphatics which are along with the vein, and then you can see a complete clearance of the common bile duct also all the nodes which are cleared along this area, and you can see this is all the nodal clearance which we do. This was an accidental diagnosis with the involvement of the serosa in a gallbladder cancer, and then once we do that, we are also taking out the segment 4 of the liver. You can see the segment 4A and 4B being taken out of the liver, that is the gallbladder bed, and this can be also done robotically. So everything that you can imagine could be done robotically, and this is how we do and completely take it out. You can see the segment 4 taken out, you can see the complete denudation of the vessels, complete removal of the fibrofatty tissue along this area, and this was one of the first one to be done robotically way back in 2013, and this was a radical cholecystectomy. Of course, can you do a gastrojejunostomy? Fairly simple. You can do a gastrojejunostomy very, very easily. You can see on both the sides the same kind, two kinds of robo. This is the robotic system which is on the CMR, where you see the two areas. This is the CMR robot. This is the Da Vinci robo. Suturing is the easiest thing that you can do. You don't have to do anything. Anybody can do this, because this is something which actually takes a very, very big advantage over a straight stick suturing, and this is the robotic gastrojejunostomy, as you can see that we are performing, and you can do this, no use of staplers. You can see how nicely you can do it in 4 layers on both the side, 2 different systems, and this is what we do. Nowadays we of course are using the barb sutures, making it much, much easier, but these are the kind of sutures you can do. Look at the ease of suturing this. And then of course this is a hepaticodocojejunostomy. This was the first Whipples that was published in a cadaver. This is a cadaveric Whipples that we did first time before we embarked on laparoscopic, the robotic Whipples. I had published my laparoscopic Whipples in hepatogastroenterology, more than 76 patients way back in 2018. And then this is the one that we started. We did the first one robotically again in 2012. Robotic, this is on the cadaver. We first practiced on the cadaver, and this was the Whipples that we practiced on the cadaver. And of course, can you do a simple thing when the patient, when the gastroenterologist could not pause, this was because of the corrosive poisoning, they were not able to put the scope, could not do gastrostomy. The other option was to do a feeding jejunostomy or a little bit laparoscopic gastrostomy. We could use this for a simple procedure like this, and we did a robotic gastrostomy. This was a lady who had consumed a lot of caustic, and there was many gastroenterologists tried to go through the esophagus. They could not do it, and the patient was almost about 18 to 19 years. We later on did a colostomy, we did a colonic bypass, but we did a gastrostomy, which is very, very simple and very easy to do. Of course, when we do esophagectomy, the big question people ask is, can you do the stomach mobilization also? Because stomach is something which is very, very mobile organ. This is a kind of area we have finished the esophageal mobilization, and we can do the stomach mobilization to prepare the stomach tube. You can see near the hiatus, near the crura, we are going there, simple, and and this is where we can do this stomach mobilization, and this is the way in which you can do this. This is the area which you can see. This is the transhiatal part of the esophagectomy. We have mobilized it, but then we can do a little bit of mobilization from here also. You can see the entire esophagus, both the crura, and then you can do this very nicely. Steady vision, precision, cutting at the right time. Now we are entering into the lesser sac, and by entering into the lesser sac, not handling the stomach tube, because this is a tube of replacement. After you break out the esophagus, you have to be very, very careful. And this is the gastric mobilization. You can see the posterior congenital adhesions of the stomach being taken out, the stomach not being handled much, keeping the stomach tube free of any kind of hematomas, because this is a replacement organ for the esophagus which is being taken out. You have to be very careful. Minute you can see inch by inch dissection, not a drop of blood, and this is the precision with which you can do the robotic surgery so nicely, and everything you can do. This is the complete stomach mobilization. These are the vasa brevi, and you can see the posterior congenital adhesions of the stomach being removed. Now, can you do something more than that? Of course, we have done robotic excentrations also for colorectal surgery as well as a gynecology gynecological surgery. So this is the entire ureter. You can see the exenteration, that is the pubic bone. So advanced surgeries where you have 2 or 3 organ involvement. Can you do this robotically? That was a question, because it is a multi-organ removal, and of course you can do this. So this is the entire bladder along with this area, and you can see this is how we can do a complete robotic exenteration. So you name the surgery and it has been done by us, and it is there, and all this you can see, this is the exenteration that we did. We also have done a total pelvic exenteration, and this we have demonstrated live in Max Hospital when this patient was referred to us, and this was done, a total pelvic exenteration was done with the Da Vinci robot. And so this is the area, you can see the total pelvic exenteration with the complete, you can see the entire area in the retropubic area, that's a cave of Rendezvous. This is the rectum along with the uterus and along with the bladder. There was an involvement post-chemo, radiation, and therefore you can see the presacral area removal. That is the entire total pelvic exenteration also, which can be easily done on both the sides. Again, the 2 systems that we have used, and we have got this. So this is the exenteration, and we also did the urinary diversion completely laparoscopically. We did the new bladder laparoscopically also, but not robotically, because I don't like to do it because it is in 2 quadrants, and this is how you can do a complete exenteration. Can lymphadenectomy be done? Very, very simple. It is one of the simplest things to be done. You are working very, very close on the external iliac artery and the vein, and nowadays with the new trends in colorectal surgery that you have to take out the internal iliac nodes, this is the latest trend which is coming from the Japanese, and a little bit of evidence also from the Stephen Wexner group. So we do the lymphadenectomy. You can see the external iliac artery and the vein being removed completely, and this is how precision, and every shot and every lymphatic is taken out. You can see and it is taken out en bloc. This is the external iliac vein, that's the external iliac artery, and then of course you can go ahead and take out, and that's the obturator nerve. You can see the obturator nerve completely, and all this is being taken out, and all these are in en bloc removal of the nodes which are there. So this is, I've already showed you the obturator. So is there an evidence, or am I speaking out of my head? This is the big question. So first, this was the experience that we published way back in 2014, 164 cases. Till 2009 in India, only urological cases were being done. I purchased the first robo in 2009, and then of course we also published robotic assisted low anterior resection, first with the Da Vinci robo and later on with the CMR robo. You can see these studies. So everything that I said has been a published data. This is the Journal of Robotic Surgery, and then robotic transthoracic ischemectomy in one of the high impact journals, Journal of Thoracic and Cardiovascular Surgery. First experience with 32. Now we have done more than 400 patients, and this is the various experience that we have got. Robotic radical hysterectomy and feasibility of robotic radical hysterectomy. Robotic total pelvic exenteration, again published for the first time, and this is the initial experience of robotic. This is again in the International Journal of Gynecology and Obstetrics. So Indian experience that we have said in the Journal of Minimal Access Surgery, a huge experience, and we also comparative study of less, that is single port surgery with multi-port surgery with robotic. We first this, and we realized that every step that you do can be duplicated using either of the modality which is there. So what is the important thing is, there is a robotic vision, the console arm which is very good. Of course you require the heart. The only limitation of course is the cost, which is also going out. The robot of course cannot perform the surgery. A lot of IT people come and tell me, I don't want you to operate on my patient. I would rather have the robot operating. Please understand, it is a master and slave relationship. The robot is as good as the operator. If you are not a good surgeon, do not know the anatomy, however best robotic system you have, a fool will always remain a fool unless he knows what is the kind thing. The surgical outcomes, are there any studies which say that robotic oncological outcomes are better than laparoscopy? The answer to this is no. So for you, with a scientific mind, please understand, it is the ease of surgery, but the outcomes, the oncological outcomes are not different laparoscopically as well as robotically, but it is these areas where you have a limited space, like you have the limited space in the thorax, limited space when you do robotic surgery for the prostate, that's where it helps you, but the oncological outcomes are not good. And what does robotic surgery do? Everybody who's sitting in the audience wants to come at a level that he can do all complicated surgery. When you don't have that kind of skill, so just because you cannot develop those skills, robotic surgery helps you to have the gap between having the skills and not having one. Take the example of the aircraft. You don't ask which pilot, whether she is he or what is his qualification. You believe the machine, it will take you from one destination to other. Robotic surgery, with a little bit of good understanding of the anatomy, helps the surgeon who are not equipped with that kind of skill to achieve the same kind of result, except for the cost. Of course, it is a skill gap filling technology which is there. Future is, we have single port robotic surgery, and recently we had a surgery in India with the Mantra Robo, when the surgeon was in, I think, Bangalore, and the patient was in Gurgaon, and the same surgery which was performed transatlantic way back in 2004, the patient was in Strasbourg and the surgeon was in New York, and this operation was named as a Lindbergh operation. Do you know who Lindbergh was? Lindbergh was the first pilot to fly the transatlantic flight. So the medical fraternity has given this operation the name Lindbergh's operation because it was a transatlantic operation which was done. So this is the Lindbergh's operation, and of course nowadays with the hologram you can put the CT scan in front of you. Not only that, the latest system of CMR, I can draw a red line on external iliac artery and a green line in the rest of the area. So even if my assistant wants to operate and cut the external iliac artery, you won't be able to do it. That is the kind of safety that we have got into this, understanding that you get a very good thing. So you can see the tools change. We have changed ourselves from typewriter to computer, and we have evolved from this kind of evolution. So technology won't replace teachers. Please understand. Technology is not here to replace the teachers, but teachers who will not use the technologies will be replaced. That is for sure, and therefore you need to understand the technology. You need to keep your minds open as you change your iPhones and cars. Please understand, this is one of the technology. It is not the ultimate technology which is available. You can do the same procedures with laparoscopy. You can do the same outcomes with open. The preliminary importance of the patient is important, and I think there we have a category, 4 categories of surgeons that we have. We have category 1 who are very intelligent and who are a little bit lazy. They write books, intelligent, but very enthusiastic and good surgeon. The 3rd category of surgeon is dumb and docile, no harm to the society, but dumb and enthusiastic. When we see a lot of laparoscopic surgeries being done by the experts and want to repeat it, see one, do one, that's not something that we should be doing. So as Steve Jobs says, we are here to put a dent in the universe, and therefore whatever technology comes your way, please embrace them, understand the limitations, understand the advantages, don't jump for it, but of course this is something which we will have to not call it as the future, but the present, with the kind of robots which are growing in our country. So thank you very much, Dr. Malhotra, thank you very much for the opportunity. Thank you, sir, thank you, thank you, thank you, thank you. You want to answer any questions? Otherwise, okay, thank you. Thank you.
Thank you, sir. It was indeed a knowledgeable session. I request Dr. Pola Singh Sidhu to kindly come forward and honor Dr. Putambekar with the token of appreciation. Despite being just 6 inches long, the pancreas quietly controls blood sugar and digestion, two systems that keep us alive every second. Commencing our next session, let's welcome on stage Dr. Varun Mehta, who will deliver a presentation on a condition that poses significant challenges for both patients and healthcare providers, pancreatitis. Evolution, treatment and complications, what to do and what not to do. Welcome on stage, sir.
Thank you for the kind introduction. Good afternoon, ladies and gentlemen. At the outset, I'd like to congratulate and compliment the Saravati team for having organized regular editions of GI Rendezvous for the last so many years. And I thank them for providing me with this opportunity to be a part of it almost all the years around. I have been tasked to discuss regarding pancreatitis. Pancreatitis, as we all know, is a perplexing situation both for surgeons as well as for the physicians. Not much has changed in the treatment of pancreatitis over the years, but yes, as the science has progressed, there have been some landmark changes in the management of pancreatitis that has led on to better patient outcomes. In the next few slides, in the next few minutes, I'll take you across those changes which have led on to better outcomes in the routine management of acute pancreatitis. I've tried to highlight the do's and do's in green color, and I've highlighted the don'ts in the red color. So kindly try to focus on that. How do you change this? Okay. Brief introduction. As we all know, pancreatitis is an acute inflammatory state of the pancreas, most common etiology being biliary and alcohol. Requires at least presence of two of the following to diagnose a patient of acute pancreatitis. The disease burden is significant. It is good to know that most of our patients, around 85%, will have mild disease and who have no mortality, and it is usually self-limiting disease. Mortality is less than 1%. On the other extreme is around 20% will have a significant disease which we call as severe acute pancreatitis, with a mortality ranging to around 35%, and these are the ones who are the focus of our attention today. So there's a need for triage of the patients who would need sort of not an inpatient treatment, and those who would need an ICU care. Those who have got persistent organ failure along with whether it is respiratory, cardiovascular, renal have high mortality. Those with infected necrosis and with persistent organ failure have a higher risk of death, and they should be monitored in the ICU settings. So this is, every one of us knows it, that the pathophysiology of acute pancreatitis involves inflammation and the triggers are either a duct obstruction or a cell injury or a defective intracellular transport. So how do we define acute pancreatitis? The definition is very simple. It is mild, it is moderate, and it is severe. Mild with no organ failure, moderately severe with transient organ failure, with local complications, and severe with local complications and with a prolonged multi-organ failure. What are the various scores? The most common use in practice is the modified Marshall score, where we have the parameters respiratory, renal, and cardiovascular. The minimum score is 0, which is the most happy situation, and the maximum score is 12, which is the worst situation. So who are the ones who have the chances of developing organ failure? One is age. The extremes of age is any disease is an important determinant of organ failure. Comorbid conditions, especially diabetes, obesity, high triglyceride TG levels. Etiology, there have been some data regarding the etiology which is got worse prognosis, but the data is not very unequivocal. Extent of the local pancreatic injury and genetic predisposition. So determinants, what are the determinants of the organ failure? I'd like you to focus on the last line, that is the timing of the organ failure from the onset of acute pancreatitis. If a patient comes to us in first week with organ failure, this is likely to be because of inflammation, systemic inflammatory response syndrome, where we do not have much to offer to the patient other than supportive care. While another group of patients who develop organ failure around 3rd to 4th week of pancreatitis, that organ failure is because of the infected pancreatic necrosis, where you have good treatment plans in your armamentarium, which includes endoscopy, which includes percutaneous drainage, and naturally medical management. So the primary organ failure has got worse prognosis as compared to the secondary organ failure. There are various risk factors risk scores available for pancreatitis, but the most common use is the BICEP, which is a bedside application where you calculate the BUN, where you calculate the mental status of the patient, serous age, and 0 to 2 points low mortality, where the patient can be monitored in high dependency unit for some period of time, but anything above 3 basically means a high mortality. So once a patient of pancreatitis comes to us, when do we do the imaging and what sort of imaging should be done? Ultrasound should be done in all the patients to determine the etiology, possibly of a biliary, if it is a biliary in origin. Whenever there is a doubt in the diagnosis of pancreatitis, because there could be many conditions that may be pancreatitis, like intestinal obstruction, intestinal ischemia, volvulus, there at that point of time you should be doing a CT scan which provides a good evidence of a presence or absence of pancreatitis. Necrosis takes around 72 to 96 hours to establish. So doing imaging just at the onset of the disease is not going to help us. It underscores the severity of the disease, it underscores the CT severity, because necrosis has not got established at that point of time. So usually it is 72 to 96 hours. MRCP, yes, if we need to know about the bile ductal status, whether there are any stones or not. So this we all know, CT severity index, and most of it, as you would note, depend on the pancreatic necrosis, that if there is more than 50% necrosis, maximum score goes on to necrosis. When do we do a follow-up imaging? Once you have done a CT, when do you do a follow-up imaging? Follow-up imaging is not routinely recommended. Follow-up imaging should be done only if you are planning some intervention. If the patient continues to deteriorate even after your optimal medical management, and you feel that doing a CT would guide you in planning an intervention like a percutaneous drainage, and that is at that time when you should do a CT scan. Otherwise, repeating the CT after a few days is not helpful to the patient. It may be harmful on the contrary by causing contrast-induced nephropathy. So what are the diagnostic lab parameters which we are aware of? The inflammatory parameters and the routine liver function test and the kidney function test. One point to note that there is no role of following trends of titers of amylase lipase. A patient comes to me today, he has got amylase lipase of 1500, 2000. I do it around 3 days later, I say that they are risen to 4000, the disease is progressing, or I say they are decreased to 400, the disease is getting better. No, that is not right way to do it. Repeating amylase lipase levels at regular intervals is not indicated, and kindly we should be avoiding it. There's one good study which says that monitoring the PCT levels over a period of time gives you the predict outcome in the patient with infective pancreatic necrosis. Those who have got PCT more than one or less than one have got different outcomes. So we come to the fluid resuscitation, which is the cornerstone of the treatment in patients with pancreatitis. Fluid resuscitation helps in salvaging the organ by optimizing the tissue perfusion, and it is indicated that we do not wait for the hemodynamic worsening. If the patient has got a stable blood pressure, even then we need to infuse fluids just to prevent the organ from getting not perfused. So gold-rated therapy is recommended. It is important to note that overzealous fluid therapy can exacerbate the clinical condition, especially by causing the lung injury, and overzealous fluid treatment should be avoided. There is a very elegant trial which was published in the NEGM, which is the waterfall trial, which actually was a landmark trial and led on to this decision whether aggressive fluid resuscitation in form of a boluses around 3 ml per kg, which comes to around 5 to 6 liters in 24 hours, versus moderate fluid resuscitation, which is around 3 to 3.5 liters in 24 hours, helps or not. So the outcome of that study was that among patients with acute pancreatitis, early aggressive fluid resuscitation should be avoided, but it actually increases the chances of a patient having lung injury, especially the ARDS, and we should resort to doing a moderate fluid resuscitation. It does not mean that fluid should not be given. Fluid should be given in a proper goal-directed manner. So, which fluid to choose? Ringer lactate is better because as compared to normal saline, we are comparing normal saline with ringer lactate. Ringer lactate is better. It is better in correcting potassium. It has got some anti-inflammatory effects. However, the evidence of superiority of RL over NS in RCTs is weak, and it is not very, very strongly established. And use of hydroxystarch as a crystalloid is avoided. So what are the targets? We keep the mean arterial pressure above 70, hematocrit to around 40 to around 40. Initially, the target for hematocrit was around 30 to 35, which has been now lowered to around 40 to 42. And we should target of urine output of around 1 ml per kg per hour. And it is very important for all our critical care colleagues to monitor the IVC diameter in these patients. And we should monitor the IVC diameter, which should be around 1.5 centimeters. That means a patient has got a normal volemic status. So, coming to nutrition, which again forms a cornerstone of therapy for pancreatitis. Initial thoughts of pancreatic rest by grazing TPN and remaining nil for orally is no longer correct. So, patients with acute severe pancreatitis is in a hypercoagulable state. There is a leaky gut with a bacterial translocation, which leads on to high chances of infected pancreatic necrosis. Giving enteral feed either by oral or by enteral method, which we will come to NG or NG, can mitigate these effects, and the nutrition should be immediately resorted to. So if a patient is unable to tolerate oral intake, early nutrition support should be prioritized within 24 hours either by a NJ or a NG. And there are different studies, even from PGI, which say that nasogastric feeding is not inferior to nasojejunal feeding in terms of infectious complications, inflammatory markers, or analgesia requirements. So either route is acceptable, but important is to establish nutrition. Kindly note that the purpose of initial nutrition in these patients is not to have a positive protein balance or positive calorie balance. The purpose is to get the gut moving. The purpose is to get the mobility of the gut to prevent bacterial translocation. And TPN should be avoided as far as possible. So this is just an algorithm to show the nutritional management, and TPN is the last which should be resorted to if the patient is acutely sick, is in ileus, or has got a very high intra-abdominal pressures. So pain initiates inflammation. If the patient comes to us with pain, we have to mitigate the pain. And of late, epidural analgesia should be considered as an agonist or an addition to intravenous analgesia. A recent trial which has been elegantly done compares buprenorphine with diclofenac and shows that buprenorphine was more safe and more effective as compared to diclofenac for pain management. So antibiotics, most of us, if not use antibiotics as the start of the therapy, antibiotics should not be used. Antibiotics should be reserved only for infected necrosis. And this is a Cochrane review which shows that antibiotics in the first week are more harmful to the patient. Antifungal should not be routinely used and used only if there is a definite evidence of fungal infection or if there is a deterioration even in spite of antibiotic therapy. ERCP in acute biliary pancreatitis only if there is cholangitis or CVD evidence of the CVD obstruction, otherwise not. I'll just skip this. I'll skip these slides. Vascular thrombosis is important. In a patient with isolated splenic vein thrombosis, do not use anticoagulation. Anticoagulation to be used only in patients who have got a main portal vein branch block. Just a brief on the management of local complications. Either it could be percutaneous or endoscopic. At 4 weeks and 8 weeks, there are different indications. The most important thing is that there is signs and strong suspicion of infected necrosis and there is a symptomatic collection. So drainage is avoided in the early acute phase. It is optimally delayed for 4 weeks when we have the best outcomes in these patients and may be required in patients with sterile pancreatic necrosis if there is evidence of organ obstruction like biliary obstruction, gastric outlet obstruction. I'll just skip this. So pancreatic collection management, it is either endoscopic step-up, it is either percutaneous step-up or it is a surgical step-up. Most often than not, the various trials have either, wherever we have used endoscopy or percutaneous, it has the step-up approach. This is a recent publication where we placed lamps in around 95 patients and we had a resolution of all the patients and surgery was required only in 5 patients. This is the picture of one of them. And upfront necrosectomy in a patient who has just been stented, yes, it could be done, but it is still a new kid on the block. Percutaneous drainage only for patients who are sick enough, who cannot be taken for endoscopic management or who have got extension into the parabolic gutters. Surgical approach is basically for patients who have minimal invasive, I think I have to go 3 slides ahead. Minimal invasive operative approaches should be performed. It could be ward, it could be laparoscopic transgastric debridement, and open necrosectomy is, it has high mortality, even morbidity, so it should be avoided. So the evolution of acute pancreatitis over a period of time is treatment changes from weeks to weeks. For the first week, we have the treatment of serous. For second to 4th week, we have the treatment of local complications. And from 4th week onwards, we treat the local complications as well as, if at all, there is a etiological thing. What are the problems in adherence to the guidelines? More often than not, serum amylase and lipase are often needlessly measured every day. Severity assessments are not performed regularly or acted upon. Even if fluid is replaced, not enough, or fluid status is not adequately monitored. So we all ask our critical care companions to monitor the IVC for patients admitted to ICU. Enterfeeding is not initiated soon enough, CT is performed very early, and antibiotics are started very early in the treatment course, and that's so broad spectrum antibiotics. So, ladies and gentlemen, to conclude, severe acute pancreatitis is a life-threatening medical emergency. Early triage is required, decreases cost and appropriate resource utilization where we can avoid ICU settings. Fluid management is a cornerstone, decreases mortality. Early nutrition has been shown to be associated with less infective complications. We need to avoid empiric antibiotics. Endoscopic drainage of the collection has made a paradigm shift in the management of these patients, and endoscopic management with lamps may evolve as a game changer. A step-up approach is always associated with better outcomes. Thank you all for careful listening. Thank you. If any questions are asked,
Thank you, Dr. Mehta. I hope your words stay with each one of us while we encounter the patients of pancreatitis. Now I request Dr. J.S. Sidhu to extend his commendations to our speaker. Moving on, it is my deepest honor and greatest privilege to invite on stage a person of greatest esteem, a truly extraordinary orator and one of the finest surgeons, Dr. Adarsh Chaudhary, to come forward on stage to deliver an interactive keynote session on his journey as a medical professional. I also request Dr. Ravinder Singh Malhotra and Dr. J.S. Sidhu to please join us on stage for moderating this session. Welcome, sir.
Yeah. So it's my honor to be sitting along with Dr. Adarsh Chaudhary, whom I came to know in the year 1999 when I was doing my residency. During that time, we would hear that who's a person who's doing a pancreatic surgery. The only one name which could come was Dr. Adarsh Chaudhary. Then in 2004, I happened to attend the GI cancer program in Mumbai, which was organized by Leelavati, where every question would come and Dr. Adarsh Chaudhary would get up. And I would say this person is so young and how come he is so much knowledgeable and he is full of energy, where all the old people who are giving the lectures and delivering their talks, so they have no answers to his question. At the end of the session, one line which he said was, I still remember that very clearly, he said, what I could conclude from this talk today is that oncology helps the oncologist. So I don't know how far that is true now, but then yes, to some extent in GA surgery, this is very, very important that most of the surgery cancers are amenable only to surgery. So welcome, sir. And since it is going to be an interactive session, we thought the doctors of our research should gain from his vast area of expertise and knowledge. So, sir, if briefly you could tell us about your journey from where you started and...
I thought this is an interactive session. I did my MBBS from Medical College Simla, then I was in PGI, then I was in Gangaram, and now I'm in Medanta Medicine. So I generally believe that these sessions should be more talking about the content rather than my association. You know, once Deepak Chopra, the famous motivational speaker, you all know him, he was asked in an interview that how do you feel when you interact with people like Roger Federer, Michael Jackson, and Hollywood stars? He said, I feel very sad when you talk of my association and not my content. So we should talk of the content, what we can talk, what we can do, because I believe medical training and teaching is at a very sad state of affairs in this country. We are passing through a very bad phase, and I was thinking like we have such a great session today, and if you see in the audience, there are no medical students. It is so sad that there is such a great organization done, but there is no audience to learn. So something definitely is missing in the way we are conducting ourselves. So I think that's what very sad for me.
If you can just share your experience over the years, like over last 20-25 years, how the doctors have changed and how the patients have changed and how the art of surgery has changed.
It's a big question, but I may not necessarily answer in that order. The first thing is, I think there's a drastic change in patients' expectations and understanding. When I was in PGI Chandigarh, patients will never demand anything. Any complication can occur, anything can happen. There's a great degree of acceptance, and there was a great belief in the doctors and the surgeons. Patients will never question. In the last couple of years, patients have become very demanding. It's very good, and it's not so good either. Patients should be aware of their rights, which makes sense, but their expectations have gone very high and sometimes to an unbelievable expectation. I believe the fault lies within us, because I believe we have not been able to, we are not trained. You see, medical training, there is no class in how to communicate. We have never been told how to convey bad news. We've never been told how to discuss the results of surgery. When I discuss with a patient for a pancreatic duodenectomy, should I tell a patient that there is a 10% chance of a complication, or should I tell that 1 in 10 patients will develop a complication? These two have very different connotations for a patient. So patients' expectations have changed. There is more access to information. They understand things better, and they also know that their rights are getting better, and they are more litigious than they were ever. I never heard a complaint against my teachers or a medico-legal case against one of my teachers. But when I was in Gangaram Hospital, there was a case against me for the first time. I felt very sad. I went to my colleague. I said, there's a case against me. He said, welcome to the club. You become a famous surgeon, because that's what happens. So that's regarding the patients. Your second question was, how have surgeons changed? I believe surgeons of today are very fortunate, because knowledge is available at doorstep. Today we need experts to analyze knowledge, not to get knowledge. When I was in PGI, I sometimes had to check an article. I had to take a bus from Chandigarh to Delhi at night, go to the National Medical Library. Go to the library, there were heaps of journals. You search a journal lying in a lot of dust. You finally reach that journal, you open it, and the pages you want were torn off by somebody. So you come all the distance, and still we could not get information. Today, information is available on the net. Everything is available on the net. What we need today is the ability to analyze that information, and unfortunately, we have not learned that. We need to be taught how to differentiate science from pseudoscience. My biggest problem is when we talk here, we always talk of successes. We always told, I did this procedure, this went well. We never talk of numerators and denominators. In life, you learn more by asking questions, not by getting answers. When I see a workshop, a complication is occurring, bleeding is occurring, people are walking out and ask, what happened? This is all nonsense, some bleeding is going on. That's when you need to sit down and see, how does this person stop their bleeding? The problem with us is that we want to see life black and white, whereas surgery, medicine, life is not black and white, it is gray. Most mistakes occur because we assume answers. We as physicians should learn to live in ambiguity. I do 100 pancreatic resections every year. I do not understand why is it that my best anastomosis leak and my worst anastomosis get well. So there are definitely factors that which we do not understand. To me, the best surgeon is one who says, I don't know. If you assume answers, we recently had an interview for a senior resident in our department. I asked one person, what is the surgery that you can do? He said, I can do everything. You give me any surgery, I can do everything, I'm an expert. So I told him, you've come to the wrong place. We are not that good. We want somebody who's able to learn. Intelligence comes not from reading. It comes from curiosity. Once you cultivate curiosity, that's what we need. I'm sorry if I sound like idealism, but I think it makes sense, because if you're curious, you learn much more. Have I answered your question?
Yeah, so
Good afternoon, sir. I'm a big fan. Been following your work for several years, and I really enjoy your communication of things scientific and non-scientific. Learned a lot from you over the years. So I have two aspects to a question. So when we were residents, I think we heard our senior professors talk about the good old days and how residents were terrible and how we would never match up to their expectations. Now I'm very mindful that we are at a stage where we are considered to be senior, although I don't feel that old, but it is, and so isn't simply a generational thing where seniors always felt that things were better before and things are getting worse now? Are we going through a generational, is it our problem rather than a resident's problem? That is probably the first question. The second question is that if you were designing a curriculum today for MBBS students, I completely agree with the fact that the challenges are unprecedented. We have much to change. How would you change the curriculum?
I'll allow both of your questions. I think we are poor role models. We are not great teachers as our teachers were. Our teachers were iconic. They had great values. We respect them. They changed our lives. I think somewhere in between we've lost the way. I may be wrong. There are so many things which you can discuss. I think we are at also fault. We have become, possibly we are taking ourselves too seriously than our profession too seriously. Why don't you sit down? So I believe that's the first question. We are equally responsible than blaming our juniors. We have to become a role model. The second question is very relevant. Our medical curriculum is outdated. In Indian system, we emphasize memory, regurgitation of data. What are the causes of pain in the right iliac fossa? So people have a mnemonic, this, enumerate, right? And an examiner wants to listen and answer which he wants to listen. I've been an examiner for many years. To me, an examination looks like an interrogation system, as if you interrogate a thief. What are the 7 causes? What are the 9 causes? That's not how you manage patients. If I had to design a curriculum, I'll make it problem-oriented. What do you do when a patient comes to you? The living example is this: majority of classes, the toppers never did well because they were merely regurgitators. They had memory, and I remember when my teacher used to teach some of them, they used to emphasize, take my notes. My notes are the truth, whereas books are the gospel truth. So we always emphasized memory. We suppressed curiosity. As an examiner, as a senior, it is not important to give the right answer. It's important to see how a candidate thinks. Am I right? If your process is right, sometimes your results may be wrong. We should emphasize processes. Am I right? That a protocol has to be followed. If we follow protocols, if we emphasize systems rather than memory, That is the communication system I like to change.
I'm just going to ask one follow-up question for surgery. So when we were training, we had access to a vast number of patients and we had a learning curve which we supplanted. Now, of course, the number of patients has changed because the ratio has changed, and equally the expectation for complications is much lower. So what can we do to make sure that surgeons who are currently in training get the same level of training as compared to, can we learn from, say, other disciplines like pilot training, for example? How can we de-risk this?
That's a very good question. Unfortunately for surgeons, we believe we've reduced surgery to a circus. We believe surgery is a technical exercise. I feel very sad when you go to workshops and somebody just shows a video of somebody has started doing a fundoplication or a liver resection. We have never shown the pre-operative reports. We have never shown the CT scan. You tell me yourself today, liver surgery is changed because of radiology. How many times we discuss radiology before surgery, that this is the plane I will go, these are the things I will do. So we have to change the whole thinking that surgery has a great cerebral dimension to it. When I went to PGI, I was told that you will never become a good surgeon because there is not much cutting given in PGI. But today, if you see the scenario in India and all over the world, boys from PGI are doing the best. Because PGI emphasized that surgery is only 30–40%. Pre-operative planning, post-operative planning is an equally important thing. And I absolutely agree with you that we've done a great disservice by increasing we spread these jam too thin. There are too many D&D centers, too many centers giving training. Everybody can do a liver transplant on a rooftop also, am I right? Everybody is allowed. Our laws are so simple, so easy that we are cutting corners. And I'm not one of those persons who believe my beliefs to be gospel truths. They are my interpretations, I may be wrong. I'm saying these things because I've made a lot of mistakes in my life. I've made big mistakes, but my only credit is I've learned from my mistakes. Some people keep making the same mistakes and call it experience, but that's a bad thing to do. I've made a lot of mistakes, and recently I was interviewed in some thing, and they asked me, what is your level of communication skills with your patient? I said, I'm not aware of it. I may interpret I'm a great guy, but my patients may not think the same. So one person who was in the audience, he said, I want to make a point. I said, the moderator said, go ahead. He said, 7 years back, me and my uncle were admitted in Medanta, and you used to come in the morning with a big group of people, and you never talked to me properly, and you never talked to my uncle properly. So I said, right, that's right. I made mistakes. So what I'm saying is that we all make mistakes, we all do, but we got to learn from them. So I agree with you that we have to change our laws, we have to change our system, and we have to give a cerebral dimension to surgery and tell our juniors, cutting is not everything. You may be the world's best tailor. If the quality of cloth is not good, your results will never come. So to choose when to operate, when not to operate, I think it's a great thing.
So there was one famous saying by a French surgeon. Every surgeon has got a cemetery in his heart, where he goes time and again to pray. As you said, the mistakes. So how do you take about this? How do you think a surgeon, and there is one thing that is second death syndrome. With every patient dying, part of a surgeon dies, a part of a medical profession dies. So how do you take this, and how the surgeons should contemplate to counter that?
You cannot counter that. The worst thing in life is when somebody is disturbed, you tell him, calm down, calm down. Never in the history of word by saying calming down, you calm down. It never happens. You have cut a vessel and you expect to calm down? It is stupid. You better react. You better throw your weight around because you have to stop the bleeding. I have killed some patients in my life. I confess openly I've made mistakes. And trust me, it haunts you. Human beings do not like profits as much as we suffer from losses. In the share market, if I make 10,000 rupees, I don't care. But if I lose 1,000 rupees, I lose my sleep. Same way when I sleep at night, those patients whom I've killed, I see their faces very often. But then I tell myself that did I do my best or not? When we're confronted with a situation, you have to think, did I do my best or not? Now, what we have a policy is, we have a complication in our department, we call for help. Few weeks back, I was doing some surgery, I cut a blood vessel. The bleeding started with torrential bleeding. So I put a stitch in the superior mesenteric vein, the superior mesenteric vein got blocked. So my assistant, some assistants are very optimistic. They just want the surgery to finish fast. He said, okay, it's all done. In children, if you even ligate the superior mesenteric vein, the collaterals form and patients do well. So those of you who are surgeons, remember a figure called 10. It's set in my mind. Whenever you do a procedure, think, how will it affect the patient in 10 hours, 10 days, 10 weeks, and 10 months, and 10 years. So I thought the bleeding is stopped for 10 hours, he'll be all right. But in 10 weeks, he's become gangrenous. So I called the vascular surgeon, he come and put a graft. So there was an observer watching me, he said, why could you not put a graft yourself? Why did you call a vascular surgeon? I said, I would have taken 1 hour, my vascular surgeon did 20 minutes. My ego is not important, it is the patient who matters. So I have made mistakes, but I've realized that calling for help, pre-operative planning, anticipating, thinking in advance, possibly helps in decreasing complications. But if you say they become zero, they will never become zero. You have to live. We all carry our cross in our heart. To say a surgeon is always successful, it means the sort of surgery we do, which is high-end, there'll be complications. But you only console yourself saying, I did my best. I hope I've answered your question.
Hi, sir. So, you have been iconic in pancreatic surgery. So, if I go in your shoes, one thing which I would not be able to answer would be that whom does Dr. Adarsh Chaudhary go to when he thinks he has hit a roadblock? So, what beyond you, if you believe that this is where I stop? That's one. The second is talking of medical curriculum. I believe that there should be, the curriculum needs to be expanded. One, which we are not taught, is interpersonal relationship, our own relationships. That's one suffers. Even, the famous heart surgeon, he accepted this in one of the interviews with Christian Barnard. And then comes our relationship with the patient, psychology. I think we lack in that. And third comes in the psychology of money. We are not taught that how to earn, how to grow. So your thoughts on that?
One of the first things is we do not understand the difference between an illusion and a delusion. Illusions are not that harmful, delusions are harmful. If you want to know the difference, in a football match in 2005, when Ronaldo used to play for Manchester United, a kick came from the side in front of the goal post, and Ronaldo jumped into the air, and it looked like he was in the air still for about 1.2 seconds. When the ball came to him, he was suspended in air. Whether it's true or not, that's an illusion. But if you think you can wear Ronaldo's shorts and shoes, that's a delusion. So I am no icon. I'm just a student of this, but I was once asked, what is my greatest achievement? My greatest achievement is my students. They've done better than me. Rajesh Bhojwani is here. he was with us. He's a much better surgeon, much better human being, much better organizer than I am. So I that way feel very fulfilled. My students are not only skill strong, but they are value strong also. It's easy to learn skills, but to learn values is very important. So I've tried my best because my teachers gave me values. So I believe knowledge, wisdom, everything should be centrifugal. It should flow away from me than to me. Regarding your second question, I absolutely believe we are very insensitive people. We don't listen to patients. The moment the patient has come and says, I have pain in the right iliac fossa, we have stopped listening to him. My diagnosis is made. It is appendicitis. So we need to learn to be patient. Surgeons have what is called as a lot of belief in heuristics. Heuristics are mental shortcuts. Anybody who has pain in the right iliac fossa, I don't want to listen to anything, it's gallstone disease. So that's what we do. We need to understand that patients don't know what a bright surgeon you are, what a great surgeon you are, how brilliant you are, what is your H index, how much you have published. They only want to know how much you care for them. And one of the best care is ability to listen to them, what they say. I also suffer from it. I also get impatient. But today my patience is just concealed impatience. I pretend that I'm listening to them. Maybe I'm not listening.
No, sir, apart from medicine, to be a whole human being, you have the other part also. You have a family, you have hobbies. So how do you manage that, and how does that help in achieving the success that you have? So was that helpful? Was that a hindrance? How helpful that was?
I'm no expert on this, and I don't think I have done full justice to my family. I'm publicly confessing I failed as a family man. I don't think I did what I should have done. And I'm very guilty of that because I did not realize that these two things can go parallel. And I'm guilty that I didn't give my time, the time I should have given my family. So I have failed there, and I know it. And to say I now regret it, it's no point. What is gone is gone. What is done is done. So, but at least I'm aware of that. Regarding hobbies, I don't know, because I don't want to sound condescending that I'm some sort of a motivational speaker or something. I don't know about that. Each of us, as an individual, I believe I became a better human being, a better surgeon, a better scientist once I started reading. Books for me taught me a lot of things. So I think I became a better surgeon, a better human being, and I could be more empathetic towards my patients after reading, because people who have no other interest get obsessed. They go home and take their sorrows. They get into a lot of politics. They get a lot of backbiting, a lot of jealousy. If your interests are something else, then I don't think this matters. Today my interest is I want to do 1,000 push-ups in 1 week. That's my greatest thing. Rather than seeing how many patients is my colleague doing, how many surgeries doing, I don't care. I have to meet my targets. I think, I don't want to prophesize, I don't want to say, but that's what I believe. We all need to cultivate some sort of a hobby to make us able to express ourselves better in society.
We have Dr. Atul Kapoor with us.
Yeah, good afternoon, and very nice to hear amongst us a very passionate surgeon and widely experienced also. I would just give one or two comments first. See, whenever we talk about medical profession and its status and future, it always ends up with a kind of criticism that we don't have iconic teachers, our system has gone down, our curriculum has gone bad. It may be true, but these suggestions and awareness are non-productive, to the sense that most of us who are in this audience, we don't have the ability to change these systems. These are, in our Indian setups, a die-hard kind of situations, and we can only feel sad about it. So what we can do with the kind of experience and sensitivities which you have just now expressed, we in the private sector, as most of us are, or even in the government sector, I think we should develop the habit of trying to, inculcate systems in our departments, in our hospitals, where we have, a kind of a robust mechanism. For example, I fail to see people who have complete data in their setups, in their departments. There are no internal audits. Most of the physicians, which include surgeons and radiologists and pathologists, we live in, kind of isolated islands. We don't share our data. We don't have interactive mechanisms. So as a result of which, we get the kind of vision after traveling a journey of 2-3 decades in this profession, that is it really all about money and settling down for oneself, or is it a true profession? So I think these are the things which practically, if you try to spread in meetings, try to stimulate young and old patients, people, I do better.
I absolutely agree with what you say. It's a very interesting phenomena with us. Even I'd like to say, we actually lack passion. We actually lack passion. When I go to meetings and do a workshop, many young doctors come to me and say, "Sir, I want to visit your center." And that interest sustains only for 1 or 2 hours. Nobody ever gets back. We by nature are not systematic. I absolutely agree. You see a patient, you ask him, "When was your surgery done?" So the wife says, "It was done in 2015. The husband says, "No, 2015, Papu got married." Okay. Then 2017, no, 2017, the roof got burnt. So they remember everything except the date of surgery. Because we as Indians never maintain data. We are not trained. Our gurus never wrote anything, because it was word of mouth. Why did Ayurveda not grow? Because it was not written. Whereas you see a small country like Italy, which may be smaller population than Punjab, produces so many papers. I'm not saying producing papers is the index. What have we contributed to the world literature in science, in medicine? Nothing. Very little. Very little. Because by nature, we are not scientific. It is not a part of our system. So my aim is that I always tell everybody, I agree with you, just maintain data. Just maintain data and try to publish something. It might sound that very condescending, but actually we have done very little. We could have been capable of much more. But that's the way we are. We are not taught. When I was in PGI, there was a class of statistics. I feel PGI was so good that they thought statistics is important. But they never told us why is it important. So all of us passed the exam just by looking left, right, and center, and we passed. And today, if you ask me one big regret of my life, I wish I knew statistics. So there is a term called in teaching called as elementitis and aboutitis. Aboutitis means that most of us know about something a little bit. Deep down we don't know. And elementitis is that we are never taught the purpose of what we are being taught. If I was told in PGI that statistics is important because subsequently when you do research, you can write papers, you can maintain your data, it will take you somewhere, I would have paid more interest. I thought it's a chore, I have to finish it, pass the exam, I got MS degree. So that's a sad part of our lives.
Any questions from back?
It's always a pleasure to listen to Dr. Chaudhary, but I want to add one point here. We are talking about the data and the research. Here is a person who, regarding international publications and research, is unmatchable both in the private and the government sector. I have remained in medical work for so many years, but in private sector, to have so many publications, there were several papers jointly with me as well, and he has been invited to be honored in states, and latest, I don't know which association, Cancer Association has invited in Japan or China, to invite just based on his research on cancer. So, we are always happy.
But he's a case report.
Yes.
There's only one.
Yes, yes.
In a population of thousands, you should be able to say there are 50. That's the sad part. That's the sad part. There's so many of us.
Anyway, we are proud of such a person. At least one. There is one. Although we are associated with him more than once. Well, the second thing we have been talking about this curriculum, as he was saying, can we put medical ethics in curriculum and teach our students how to maintain the ethics once you become a doctor? If I start narrating what's happening in the professions, I would myself feel ashamed. There's so many things which I can't quote, but so the medical ethics is an important aspect. I would not mention anything, but I am observing, he is observing, you are observing.
Can I say something about it?
Yes, surely.
Please sit down. Do we have to be taught ethics? Just by putting in curriculum, will we learn ethics? You ask yourself a question. If you say honesty is the best policy, it's a stupid statement. Why should it be a policy? It's a natural thing. Just by incorporating ethics, we don't learn ethics. We are role models. We do things. The problem with most of us is we have two sets of rules. One for me, one for others. This is the sad part. So ethics is something which the voice comes from inside. I agree with you, but I don't think curriculum is there. In the audience is Dr. Y.K. Chawla, who's been himself a leader, who knows. He will agree with me that the institute provides all the facilities. Dr. Chawla, I want you to say something. Yes. Dr. Chawla, the institute does so much.
I think that's a very valid point raised. Ethics needs to be discussed more often. Maybe in the curriculum it may not help much, but certainly you have to be role models for the youngsters, which probably is not happening. Even we have probably failed in being role models for the students. So you have a very valid point. Curriculum could be included of ethics, but that has to be practiced.
Yeah, please go ahead. Please.
Good afternoon. I really want to congratulate the organizers for having this session here. Dr. Chaudhary, it's been a pleasure to listen to you. Usually we attend conferences and they're jam-packed, 15 minutes, 15 minutes, 15 minutes, 15 minutes, we have this session, we have this session, we have this session. But to be able to discuss such things is actually something, I think it's a need of the hour. As far as the question of medical ethics being included in the curriculum, you are right when you say that ethics does not need to be taught, right? It comes from inside. But there are many a times when such things are being discussed, and when in the rat race or the race of everyday life, sometimes these things get ignored or neglected or maybe forgotten. And if someone as a role model, as for example you listening to you, or maybe somebody just happens to mention those things, it does make a difference in somebody's life. I've been in a school where nuns used to teach us, so we used to have a period on moral science every week. At that age, I used to think it's such a waste of time. Why do they have to put this period in that? But now, when I think about it and I remember and I recall all those things that I was taught at that time, does make a lot of difference. And it has really helped me in my life now. And I'm sure if at that age of growing up, when we are taught, as you said, by rote, remember anatomy, relation, we don't even remember. At that time, we are learning. We don't understand why it is important to remember the relations. I am a radiologist now. Now I know the importance, what is behind the duodenum, what is to the left, what is to the right. At that time, I never knew about it, right? Even that really jam-packed curriculum, if we do have a lecture or a period of medical ethics in which little things are discussed, maybe just as Dr. Amitabh said, interpersonal relationships, patient-doctor relationships, little things, just discuss sometimes, stay in the mind and maybe help later on.
You have a point.
Good afternoon, sir. Sir, I have two questions. Like we were discussing medical curriculum. As a medical teacher, first I want to know that every year we have to give thesis topic or the research topic. How far do you think that, what sort of research topic to be given to the PDs, or it is just a hoax?
It's a hoax.
So should we continue with this hoax then?
You see, we are discussing, these are useless topics.
Right.
We have no teeth. We are wasting time. We are not policy formers.
Sure.
So this is a wastage of time. Ethics should be included. We are discussing issues, what we can do.
Right.
Let's discuss what we can do. It's in our hand. There is no medical person sitting here. So we should discuss what is in our hands.
And the second thing, sir, I wanted to ask that, like every patient teaches us a new thing. And over the time, surgery has progressed from open to now the robotics. When should a surgeon decide that he has to continue with the same technique or enter a new technique, or is it just a rat race that we have to learn every time a new thing comes in the market?
First, on the lighter side, even if you win a rat race, you still remain a rat. So to say that, oh, robotic is very good, open is very good, laparoscopy is very good, it's a very difficult question to answer. And there are no answers also to this. So long as you can do a procedure well, in a scientific way, be honest to yourself, you should do whatever you want. You say that, you know, I learned this very late in my life, that to accept another person's point of view as a point of view. I used to be against laparoscopic surgery many years back, and I told one person, Murray Brennan was a very famous surgeon in Sloan Kettering, a man I respect a lot. So I met him, I said, are you doing laparoscopy Whipples? He said, I don't do. He said, do you do? I said, I don't do. He said, why don't you do? I said, I don't think it works. He said, that's not true. Maybe it does not work in your and mine hands. It might work in somebody else's hands. To say that this is best, you have to accept the policy of dualism. There are multiple ways to reach God. You can do a good cancer operation, open, laparoscopic or robotic. It doesn't make a difference so long as you do it well. That's my answer to the question. Yeah.
Dr. Bhojwani.
Sir. Did you hear me praise you or were you in the hall?
No. So, I'm not only your student, I'm an ardent follower for so many years. You're a role model also. I've been watching you for so many years. It's been almost about 25, 30 years. I want to understand from you, what is the key to stay relevant in this world as a surgeon, with the paradigm changing so often, technology, facilities, market, pressures, science, research, everything is changing so fast. What's the key to stay relevant as you've been all the time?
First of all, in all humility, I don't think I'm very relevant, but I think we all need to have a degree of restlessness. I I am a great student of curiosity. I think so long as you remain curious, one thing leads to another. He said a very valid thing. I think if you audit your own data, lot of learning comes from it. Am I right? When you eyeball your own data, sometimes I realize I've made the patients much worse after surgery than they were before surgery. I think the key to life is not in getting answers, it's putting the right questions. Look at your own career. Look at your own career. How you started and where you landed. It's essentially, I think, all people who are successful have one quality in them. They believe that the locus of control is me. Not that when I failed, my father didn't support, my this support. When you believe I am responsible for myself. So I go to a meeting, there are people who hate me, who want to always prove me wrong. When I give a talk on pancreatic cancer, I knew they'll be there. They'll ask a question which will make me feel small, so I read everything before that. Because I know they're going to pull me down. So they are your biggest supporters, people who are your criticism, who give you think. So you have to protect yourself, and to protect yourself, the only power is the power of knowledge. What else do we have? We have nothing. The power of knowledge. So long as you keep reading, so long as you keep yourself well abreast of things, I think you stay relevant. I hope I've answered your question. But your question had the answer hidden in it. You already know the answer to this.
Very good morning, sir. You would have treated many complicated patients who would have landed up with complications done by some other surgeons. So how far do you go in safeguarding the primary surgeon, as it is very easy to be wise in retrospect?
It's a 100% protecting the primary surgeon. But what happens is the primary surgeons themselves harm so much many times that we cannot protect them. What I mean is today's patient is very awake and alert. I've been involved in many medical legal cases. I must have appeared in 18 court cases of violent injury against the primary surgeon. And invariably the surgeon who informed the patient that something has happened never had any punishment. Patients, at that time it's very difficult, but at that time patients feel bad, but the judge, the judiciary supports, because we say that 0.2%, 0.3% incidence of injury is known. So it can happen. But when you don't tell the patient tells something else, that's when a problem. But we make all the effort to protect the primary surgeon, because I as a surgeon know I myself create so many complications. So we always protect the identity of a surgeon. But a surgeon also has a great responsibility that he should conduct himself in a proper way when a complication occurs.
It's not a question, it's a little bit of a pushback to what you just said and discussed. I think we discussed a lot of things with the feeling of helplessness. So we can't change the system, we can't do this, we can't do that. I think we have a little bit more agency than we think it's possible. You know, Maya Angelou said that the biggest risk is not in recognizing your agency and thinking that you have less, you can do less than you can. I suspect that a lot of us can do, because we may not be making policy in the
That I agree. So I agree. Yeah. Because progress is not one big change, it's a series of small changes. If we change ourselves, things will happen, but I agree. I agree.
Good afternoon, everyone. I know I may not be a member here, but I would like to highlight here that new medical education has started putting communication as a part of orientation program also, and ADCOM module has been brought up by NMC, and they are teaching the students, medical students, undergraduates about the legal implications and ethics also.
Great.
It has started coming up. Let's hope it turns out to be good.
That's good news, that's good news.
Sir, one last question from my side. What do you think about the medical legal issues which is happening, and now do you think we have started practicing more of a defensive surgery or a defensive medicine, and what are your views on that?
Yes, we definitely are practicing defensive medicine, at least we are. We are in a very highly litigious society. We practice a lot of defensive medicine, but I myself had many problems, issues, and in 100% of them, the issue was a lack of communication or a miscommunication. Because there are so many people involved in communication, I think, like the lady just said, we need to communicate in a much better way. When I was young, hospitals didn't have a counseling room. Not all hospitals have a counseling room. It cannot be more. There are two things which are important today, I realize. One is counseling, second is a consent form. If you want to save yourself medico-legally, counseling and your consent forms have to be absolutely flawless, because the court only sees two things. If you inform them beforehand and your consent form is okay, you can get away with nearly everything. Unfortunately, what happens is our counseling is very sketchy. We should formulate a way that I will tell 5 things in this counseling. Have the 5 things been answered? So if you have those 5 things answered, that you tell the patients what is the need for surgery, what are the side effects, is there any alternative thing available, any other procedure is there, and last thing you must ask a patient is there any question that you want to ask? So once you give them option, I believe it's all because of lack of communication. We are so busy that we forget that we have to talk, and patients sometimes irritate you, they ask stupid questions, but what to do, we have to do that. That's my belief in that.
Yes, sir. Thank you.
Wonderful. The task.
Thank you. Thank you, sir, for sharing your words of wisdom with us, and we believe that the lessons learned today shall stay with us throughout our lives. Now I request Dr. Ravinder Singh Malhotra and Dr. J. Sidhu to felicitate our esteemed speaker. Are required to go to Hall 3 and submit their posters and papers.
Pancreatic cancer is silent at first but demands our loudest vigilance and strongest science. So, to discuss a little more about the silent killer, let me invite on stage Dr. Rajesh Bhojwani to present on the topic of pancreatic cancer decision making with newer insight.
campus में whenever I talk to people, I'm not always saying why. I'm sure there are. So, I mean, I have to reschedule because I took my tickets and all that, so I spent time with them. But I'll give you a feedback. Did I tell you about the delivery stand house or no? Wasn't very good. 5 years in IS. That was in a trouble. Yeah, it was. I couldn't. The last sort of I used to work on polymer composition, fully reversed. So we go PhD and I think we've reached the right formula. We formulated look at the looking like this now. So they're 3D printed and gold. So we're getting about 10 prints here. I have clips to it and videos to it because so our first big so then it's a fabrication problem. So now this is nice and bendy, it's decorating and it's predictable. It's not causing any blockages. So it's not causing any reaction. Yeah, exactly. When if it degrades and forms older vessels, and so I think that's why it's very good. Now fabrication is another challenge. Because we're getting it for endoscopy. So now we've done 3 things. Elastic. No, there is an there is something called an Archimedes line. Currently we do fully degradable but if you handling properly, that's something very tight. Distinguishing the simple status from can do away with I'm trying to work with IASC because I see a problem is I see IITs are much more application driven. I see much more science driven. So I see for a long time now. Actually, we have a funded project on an electronic notes for HE diagram. Instead of using MS, right, last spectroscopy, use a sensor array. So ये पिछले 5 साल से मैं कर रहा हूँ. मतलब sensor array से ही डाल रहे हैं. 3 लोग चलते हैं. But they're not like honestly, I'm pretty sure if I would go to IIT, I would probably couldn't respond by now. Yeah. Hyderabad is really well. I'll let you know when I go and meet you. I can make it. I'm leaving now. My flight's at 4. I'll be there with you. Yeah.
Dia berarti kena je kerja ke berarti di mana itu dia. Nonton lagi orang apa ni? Tangan sana tentang ada ni. Ini kan ada. Ya betul. Itu lapar ni. Charge lapar. Itu apa lagi? Kiri. Ada berada seperti lagi. छोटी में गाड़ी चल तमाम ना जाओ emergency के लिए स्टार्ट करते हैं ये प्रॉब्लम है मैं तो भी
Very good afternoon. Thank you, Dr. Malhotra and the team for inviting me over to Amritsar again. It's always a pleasure to be here. I'm myself a student of Dr. Adarsh Chaudhary, sir might have left. And most of what I've learned about pancreatic cancer is actually from him when I was at GB Pant. Through this presentation, it's a brief presentation, and what I'm trying to do with this presentation is to give you an overview about how management of pancreatic cancer is changing and what is the future looking at. If you look at this slide, pancreatic cancer has risen in incidence in the last 25 years, as we've seen. Most of it is because we now pick up more cancers through imaging based on their symptomatology. But if you look at the results of treatment of pancreatic cancer, even today, there has been a very, very modest increase. And even today, we are looking at just about 10 to 12% of 5-year survival if you take all the pancreatic cancers in one box. Even if you identify some of these patients in the early stages, the maximum that we are looking at is about 30 to 40% of 5-year survival. But these cancers which are picked up in early stage are not very many. For the last almost about 90 to 100 years, one important hallmark of treatment of pancreatic cancer is to resect it out in toto, not leave any pancreatic cancer tissue inside, what we call R0 resection. And everything else, be it chemotherapy, be it immunotherapy, be it early pickup, everything is revolving around this particular fact that unless you take the pancreatic cancer out with an R0 resection, you cannot kind of look at a prolongation of survival in these patients. Even if you try and look at this particular graph, you will get to see that 1935 was the first Whipple's operation, as we commonly call it. Today it's almost about 90 years. The operative understanding and the results have improved, and most of the high volume centers now give good results with less than 1% mortality. High volume centers would mean more than 24 Whipples per annum. But the morbidity and the morbidity of the procedure still remains around 30%. More and more centers are now getting better at pancreatic duodenectomy. The conventional workup, as we understand today, has been, as all of us actually practice in our day-to-day practice, we do a pancreatic protocol CT, we identify the lesion, biopsy, we make an attempt. If it comes out, it is okay. Otherwise, in a resectable disease, as per guidelines, we don't even need biopsy in a good clinical setting. We can proceed with resection. CA19-9 is one of the tumor markers. If it is very high, some guidelines say 1000, some guidelines say 750. We do a PET scan to rule out a metastatic disease, and sometimes we do a staging laparoscopy. So this is the understanding of the entire treatment paradigm for pancreatic cancer at the moment, which is followed in most of the centers. My topic today is how decision making impacts the outcome of pancreatic cancer. And it has now been amply shown, if you look at this, that decision making impacts the survival of the patient right from the OPD. When you identify these patients in the OPD, when you work them up, when you take them to the theatre, when you take them to the ward after the theatre, and how you follow them up. And each of these small points actually make a difference to the survival or outcome of these patients. So look at this. This is all data proven. If you make good decision based on the evidence and the research, if you follow optimal decision pathways, quality of life of the patient becomes better. 5-year survival improves from 5 to 8% to 20 to 30% in the same patient, same scan, same lesion. If your decisions are better, the 5-year survival increases from 5 to 8% to 20 to 30%. The R0 resection rates increase from 30 to 50% to almost about 70 to 90%. Perioperative morbidity reduces to about 20 to 30% from 70 to 80%. And of course, the cost of care becomes huge if you do not make proper decisions. Today, as are other cancers, even pancreatic cancer should ideally be treated by a multidisciplinary setting. It has been now very convincingly shown by the data from the West, from the Johns Hopkins University, that if you make a pancreatic cancer MDT, the initiation of proper treatment in these patients starts at least about 2 to 3 weeks earlier, which is significant in these patients. Approximately 25% of these patients, they finally deserve multimodal therapy, they do. And many of these patients, if you expose them to the multimodality treatment, they come back with decisions which are patient-centered, and most patients say that they have less decision regrets after they meet all these specialists who are going to treat them. What I mean is, if the pancreatic lesion comes to you and you are a surgeon and you can take it out, rather than you taking all the decisions, it is important to have a team of all the disciplines which treat the patient, where the patient is in the center and the decisions are taken collectively rather than you and the patient taking it. Look at these small changes which make a decision change and which impact the overall survival of these patients. Conventionals, many of us get to see a patient comes to us with a pancreatic cancer. You'll sometimes wonder that I referred a patient for pancreatic cancer, why did they repeat the CT again, or why did they repeat the CT with CT angio again? Well, it makes a difference. Small things make a difference. Sometimes I find it myself very difficult to advise a patient or repeat CT scan who just got two days back a CT scan from some other center, now comes for surgery, and ask him to get a repeat CT after 3 days. The patients also find it very funny because they don't understand the difference. But as the pancreatic specialist, we do understand the difference, because it has been shown that if you take 1 to 1.5 mm slices with a multiphasic dual energy CT, the pickup rate is higher. Functional MRI, the pickup rate is higher. If you do an FNAC EUS guided, the yield is smaller. If you do FNAB, which means a wider bore needle for EUS guided biopsy, the yield is higher. And overall, the clinical impact, the borderline resectable patients are picked up by more than 20 to 30%, and that can be subjected to neoadjuvant protocols. As I mentioned earlier, it is not about you as a surgeon taking all the decisions, because the patient's aspirations are different, patient's understanding is different. With such a complex disease which is to be managed by at least about 10 different specialists, it is important to keep the patient in the center, because you have only technical factors in mind as a pancreatic surgeon, but the patient has certain other factors in his mind, and these have to be optimized always. Look at this. Like esophageal cancer, like gastric cancer, like rectal cancer, we now have data that if a pancreatic cancer is treated only by surgery, I'm talking about the borderline resectable cases, if you institute neoadjuvant treatment with it, the 5-year survival rate increases almost by about 10%. After imaging, the decision making comes on the basis of CA19-9. This is a tumor marker which is raised in about 70% of patients, but we fail to sometimes remember that 30% of these patients may have a false negative CA19-9 despite the tumor being there. And that is why we have to check the Louis antigen to make out if the patient is there, because there is false negative. And these days, we have more markers like ctDNA. Today, the ctDNA is done in US. There are 2-3 companies. It takes about 3 weeks for the report to come back. You cannot wait for 3 weeks before surgery, but follow-up, certainly you can use it. But it's not
the day is not too far. Within about 2 to 3 years, you will get to see all of these molecular markers readily available at your hand, and you will not be actually basing your decision to surgery or operate only on the basis of CT scan or CA19-9. There are 5 classifications which have identified these key molecular features, and based on these key molecular features, we now understand as to which pancreatic cancer has a better prognosis and which has a worse prognosis. And once you do all these panels based on the liquid biopsy, the ctDNA, all of these molecular markers, and then try to correlate it with the imaging and CA19-9, you will know which patient is going to do well, which patient is not going to do well. Many a times we do a wonderful surgery, send the patient home on 7th day or the 8th day, but find him coming back with metastasis within 3 months in the liver. Now those are the patients whom we are going to pick up with the help of these markers, and in the future, we are going to subject these patients with bad markers, with worse prognosis, to more aggressive neoadjuvant therapy rather than less aggressive neoadjuvant therapy. Because we have shown, the data has shown, that if you do fall-free NOx, it's a more aggressive therapy with more toxic effects, but the conversion to resectability is higher as compared to gemcitabine-based therapy. Second, next thing comes regarding the decision making. This is the frailty index. Nowadays, we don't take every patient of resectable pancreatic cancer to operation theatre directly like that. We have our own understanding scoring systems of identifying which risk patients. And these high risk patients are also, now there is this concept of frailty, how frail they are. And for example, we measure the sarcopenia index. So we do a CT scan, and at the level of L3, we identify the muscle mass, and there's this formula which we identify, which is this formula. Their cutoff values are there. And if the males fall below 52 and females fall below 38, be prepared for a higher mortality, higher morbidity, less overall survival, and increased length of hospital stay. And therefore, these patients might need to either go to prehabilitation or discarded from the surgical list. And therefore, not a hallmark. We don't depend on the age. We depend on the molecular markers. We depend upon the performance index of the patient. That's how, you remember this patient, she was 93 years. We operated her last year. We subjected her to Whipple's. When they went around and talked to other physicians and surgeons, and they said that it was madness. Why were we trying to do it? But the patient wanted a better quality of life. And at the age of 93 years for pancreatic cancer, she underwent a surgery lasting for 6 hours, day 11, and today at almost about 9 to 10 months after her surgery, she's doing well without recurrence. How to choose patients is changing. And leaving those patients to their fate have become unresectable in the light of the knowledge and the research in the last 5 to 10 years. As surgeons, we are becoming more and more aggressive. These are the various advantages, more and more aggressive. These are the various advantages of we do almost about 40 to 50 Whipples per annum, and out of which just about 4 or 5 would be laparoscopic. But the prime reason why we don't do too many laparoscopic procedures for Whipples, I have done it at several workshops 10 times. But then you have to have that team which is geared up for doing the laparoscopic Whipples. It takes about 7 hours, 8 hours, and it's expensive also. It may not be involvement. We classify them as borderline resectable or locally advanced. If it is less than 180, it is borderline resectable. If it is more than 180 SMA, it is locally advanced. When it is borderline resectable, meaning less than 180 degree, these patients are given neoadjuvant therapy to make the margins negative, so that we are definitely going ahead with surgery, but we are aiming at a R0 resection. But if it is more than 180 degrees, then since we classified it as locally advanced, we are not really sure whether we are going to stay ahead or go ahead with the surgery. These patients will still be subjected to neoadjuvant therapy and a repeat imaging. Based on the response, we'll go ahead. But this is the place where probably molecular subtyping will help, and the tumors with better subtyping probably will go for more aggressive resections, including the arterial resections in the future, I'm sure. Thank you.
so much, sir, for your valuable words. I would like to invite on stage Dr. Varinder Singh to please felicitate our speaker.
Drug-induced liver injury, where healing hands must tread with caution. Proceeding to our next session, please welcome on stage Dr. Yogesh Chawla to help us master the topic of drug-induced liver injury. The stage is all yours, sir.
Yes, that's it.
Thank you. Grateful to Dr. Jayarath and his team for having called me over here. This is a very important topic for the doctors as such. And we all know that so we all know that drug-induced liver injury mimics almost all liver disorders. And you have different types of drug-induced liver injuries. These could be direct, indirect, and idiosyncratic. Most of these injuries are direct and they are predictable, they are dependent on the dose that is given to these patients, whereas idiosyncratic are unpredictable and may be associated with other immune factors. So there are different factors that lead to drug-induced liver injury. The drug-related risk factors, one could be dose escalation, development of reactive metabolites which affect the bile salt export pump, drug interactions which works through the CYP450 enzyme inducers. A good example is rifampicin, INH, combination leads to toxicity. Carbamazepine and phenytoin all increase the chances of valproic acid toxicity, and if you give multiple drugs, more chances of having drug-induced liver injury. Even host-related factors are important. Elderly individuals, females, alcohol-related individuals, they are more prone to have drug-induced liver injury. If anyone has a pre-existing liver disease, some of the drugs tend to produce drug-induced liver injury, and so also if diabetes and obesity is there, the chances increase significantly. Genetic factors, as we know, related to INH and other drugs are responsible. These could be HLA or non-HLA dependent, and now there is more and more studies to suggest that gut microbiota also is responsible for drug-induced liver injury. So when a patient comes to you with jaundice, how do you make a diagnosis that possibly it's drug-induced liver injury? It's a diagnosis of exclusion. So medical history is absolutely important. And what we all falter is we don't take out the history of complementary and alternative medicine in these patients. Some of the drugs are very obvious. The causal relationship is very clear. You give Augmentin, patient develops jaundice after some time. You give INH rifampicin, patient develops jaundice later, especially those who are prone. But we don't exactly take out the history of complementary and alternative medicine. The supplements which are so often used by patients in India. So you have to have a detailed medical history. Ask for any medications that have been taken in the last 6 months, previous exposure, comorbidities, concomitant medications, and try, if possible, to look at the pattern of the lab tests before and after discontinuation. Some of the drugs produce drug-induced liver injury immediately. There are others that take longer latency, like nitrofurantoin and methotrexate. Topical formulations do not lead to drug-induced liver injury, and you can identify whether idiosyncrasy or intrinsic dose-related drug-induced liver injury is responsible for hepatitis. So you suspect drug-induced liver injury, DILI in short, if there is a significant increase in SGOT, SGPT, alkaline phosphatase and serum bilirubin. Mark you that raised bilirubin, raised INR and low albumin, these are all markers of severity. When you start any drug, suppose the baseline liver functions are abnormal. When they become double the baseline, then you should start doubting of drug-induced liver injury. Or if the patient develops symptoms of liver disease, but we need to rule out causes which are responsible for jaundice, like viral hepatitis, alcohol. There are some drugs which produce a liver adaptive response of transaminases. And one of the familiar examples is INH and statins. You give these drugs, there is a mild rise in enzymes, and we attribute this to drug-induced liver injury. That is not true. The enzyme should be at least 5 times the upper limit of normal, or alkaline phosphatase should be 2 times the upper limit of normal to classify it as a real drug-induced liver injury. So, like you have in portal hypertension, clinically significant portal hypertension, when the portal pressure is more than 10 millimeters of mercury, you also have a similar terminology as clinically significant DILI when the AST-ALT is more than 5 times the upper limit of normal, bilirubin more than 2.5, INR more than 1.5, on 2 separate occasions 24 hours apart. About 10% of patients with drug-induced liver injury require a liver transplantation. 17% of them go into chronic drug-induced liver injury, and elderly individuals more often develop cholestatic liver injury, especially above 65 years. When you do an epidemiological study, almost 20% of the general population has abnormal liver functions, and 13% of them have persistent altered liver enzymes. And these could all be attributed to fatty liver disease, alcohol, hepatitis B, C, the causes of which need to be ruled out and treated accordingly. There is a formula where you tend to differentiate these patients into hepatocellular jaundice, cholestatic jaundice, or a mixed form, and that is the R formula, which takes into account SGPT and alkaline phosphatase. DILI could be categorized into acute, subacute, or chronic, and mild, moderate, and severe depending on the levels of liver function abnormalities. So what is most important is before labeling a patient as drug-induced liver injury, you should exclude a lot of competing etiologies. The hepatotropic viruses, we are all familiar with hepatitis A, B, C, HEV, But even non-hepatotropic viruses like CMV, Epstein-Barr, or herpes simplex may lead to hepatitis. Alcohol is something very common. AST-ALT ratio becomes more than 2. So that gives you an idea if the patient is hiding alcohol intake. And now you have a test known as serum phosphatidylethanol, which you can estimate in the serum, lasts for about 28 days. And if somebody is not coming out with history of alcohol, this is a good way of picking them up. Raised GGTP and raised MCV are also responsible for abnormal liver function, for finding out people who don't come out with alcohol. But the other causes, you're all familiar, autoimmune liver disease, you have to have autoimmune markers. Here I would like to mention there is a new terminology known as drug-induced autoimmune-like hepatitis. This happens with almost 40 different drugs, and the common ones are nitrofurantine, methyl dopa, interferon, complementary and alternative medicines, statins, and more importantly, the antineoplastic drugs and immune checkpoint inhibitors. They are very common. So you need to do liver imaging to prove the diagnosis that patient has DILI and this particular drug is responsible. You could re-challenge, but this is usually avoided because it can turn out to be life-threatening. So you have to assess the causality assessment whenever these patients come to us. And you have different versions like RUCAM, RECAM, where you have different parameters and you come to a conclusion whether the patient has drug-induced liver injury. Although this whole method has some limitations, you may have to resort to expert opinion, and only then you can give a diagnosis of definite, highly likely, probable, possible, and unlikely. Liver biopsy may or may not be required, but it is recommended only if you're not able to rule out competing etiologies, if there is evidence of pre-existing liver disease, persistent worsening of the liver functions, and if the liver biochemistry remains abnormal for more than 180 days and it does not decrease by more than 50% in 30 to 60 days. So when you do a histology, you have a whole lot of different characteristic pictures which can pick up different drugs which lead to, like granulomatous inflammation would be more often in patients with sulfonamide drug-induced, phenytoin, quinidine, carbamazepine, and so on and so forth. So cholestasis, whether it is bland or it is chronic, and there are some drugs which lead to sclerosing cholangitis also. The antineoplastic drug like nivolumab is very common. Amount of steatosis also gives you information from liver biopsy. But I want that you should also remember that hepatic adenomas may also be documented on a liver biopsy as a cause of chronic drug-induced liver injury. So also sinusoidal obstruction syndrome, more often with antineoplastic drugs, nodular regenerative hyperplasia, or obliterative portal venopathy, again with antineoplastic drugs and some others. So you get a lot of information on a liver biopsy. So just in brief, I'll tell you that patients who have a pre-existing liver, there are some drugs when you give, the toxicity is worse. And this is the group of patients who may require a liver transplantation. Mortality is more. And patients at least who are the Child's Puke score B and C, that is the decompensated group, they are more likely to have drug-induced liver injury. And the commonest cause of DILI in this group is antitubercular therapy, because the two tend to coexist, and anti-HIV therapy. Hence, it's very important to closely monitor these patients. Anyone who's hepatitis B positive also may be more prone for reactivation with antitubercular therapy, and it has been shown that those who have a replicating virus, E antigen that is positive, are more likely to develop DILI. Those who have been on antiviral therapy, anti-HBV3 therapy for at least 1 year, DILI would happen less with antitubercular therapy. We are always scared of giving statins, but it is a very good drug. In spite of rise in enzymes, it usually does not lead to any worsening of the liver functions, and in fact, it not only decreases the chances of decompensation, but also development of HCC. And fatty liver disease, which is very common in our population now, these patients are also more prone for drug-induced liver injury, and whenever it happens, the recovery time is longer. So, suppose someone has a silent hepatitis B. For obvious, you would be aware, but whenever you're giving immunosuppressants, antineoplastic drugs, you have to be very careful. Find out whether the patient is HBsAg positive, HBV DNA positive, or anti-HBC positive total antibodies. Because this is the group of patients with immunosuppression, they are likely to get reactivated. Hence, anyone who's positive, before you give chemotherapeutic drugs, should be given prophylactic antiviral therapy 2 weeks before you start, and continue after you have stopped the therapy at least for 6 to 12 months, and in some situations 18 months. So this is very important. You need to remember, we come across patients where hepatitis B is not tested for adequately before giving chemotherapy, and these patients come to us with flare. So it's also important, after you have stopped the chemotherapy and the anti-HBV therapy, you need to monitor HBV DNA. HCV reactivation also may happen if anti-HIV therapy is given. Now, coming to the most common cause of drug-induced liver injury, these are the antitubercular drugs. And as we all know, that INH, rifampicin, pyrazinamide, they are highly hepatotoxic. And even the second line, like prothionamide, is highly hepatotoxic. And it is one of the commonest causes of acute liver failure and acute or chronic liver failure. Usually, DILI occurs in this group of patients within the first 2 months, and hence these patients should be monitored very closely every 2 weeks for the first 2 months and 4 weeks later on. If patient has been taking alcohol or has a normal baseline liver function, do close monitoring even more frequently. Another important group which I want to address to this audience is the herbs or the complementary and alternative medicine hepatotoxicity. This in short is also known as HILI, herbal induced liver injury. And we know that Ayurvedic drugs and supplements, most of the Indians tend to take this, at least after the age of 20 years. These are usually not single ingredients. They are multiple ingredients which have not been adequately studied, and different chemicals are added to it for enhanced results. And one clear example is the anabolic steroids, which given in the gym in combination with protein powders land up these patients into drug-induced liver injury. There is also batch-to-batch variability, supplements are added to it, and also contaminated heavy metals. So some of the common examples which you all must be coming across, Herbalife for weight reduction is one of the important causes of hepatotoxicity, so also ashwagandha, green tea extracts, turmeric, and aloe vera, datura, etc. So one has to be very cautious. And this particular study, which during COVID times was assessed, and they found that almost 43 patients with drug-induced liver injury in the country had consumed giloy. And on histology, they all had shown features of autoimmune like hepatitis. And another new culprit which is coming up for drug-induced liver injury is the antineoplastic drugs. And the most problematic one is immune checkpoint inhibitors. If they are used singly, then less than 10% get DILI. But if they are used in combination, which usually is so, more patients tend to develop drug-induced liver injury. So these people have extrahepatic immune events as well. And liver biopsy is usually a must after the patient is stopped with checkpoint inhibitors, and if the bilirubin doesn't respond or does not come back to normal, then you do a liver biopsy. Usually they have autoimmune-like features. Give them steroids for a period of 2 to 3 months, and most of them recover. Acetaminophen hepatotoxicity is not common in our country as compared to the West, but there is always a fear amongst the physicians that giving paracetamol is harmful. It is harmful only if you give more than 4 grams at a single time point, or if someone has chronic liver disease, if you give more than 2 grams at one point of time. But we are all familiar with the antidote N-acetylcysteine. NSAIDs, the culprit usually is nimesulide. Aspirin may lead to hyperammonemia in infants by producing Gray syndrome. Methotrexate has been associated with chronic liver disease. Steroids also may worsen the pre-existing liver disease because it increases the fat within the liver. And IV tetracycline, halothane, and azithromycin are other common causes. Otherwise, you have a very long list of drugs that produce drug-induced liver injury. I've just identified some of them which we all should be more aware of. Prognosis is usually good in 80% of cases in whom the DILI is mild, but some of them may go on to acute liver failure, acute or chronic liver failure, and even chronicity where they come up with cirrhosis and nodular regenerative hyperplasia. Situation which is very problematic is cholestatic liver disease, which develops ultimately into vanishing bile duct syndrome. This is another term that you should be aware of. Just 2 days ago, I saw a patient with pancreatic malignancy. He was stented, developed infection, given augmentin, and in about a week's time developed jaundice, which rose up to 40 milligrams, which did not come down in spite of all the supportive medicines. Plasmapheresis was given, and it got plateaued at 15 milligrams with supportive steroids. Patient doesn't have much symptoms, but he's moving with 15 milligrams bilirubin. And I presume that after some time, this patient would develop vanishing bile duct syndrome, for which the answer is a liver transplantation. So it can be that bad. Just to tell you a little data about the Indian drug-induced liver injury, almost from 1,300 patients, 46% are because of antitubercular therapy, 14% because of complementary medicine, and 8% because of antiepileptics. Even oral contraceptive pills lead to about 3.5% of DILI. And acute liver failure cases are reported in the country. Acute or chronic liver failure, if it happens in DILI, has a worse prognosis as compared to the other group of acute or chronic liver failure. So treatment is you discontinue the drug as early as possible, admit to a liver transplant unit if the patient develops abnormal mental status, vomiting, coagulopathy, and dehydration, which are all indicators of severe liver injury, indicating that the patient may go into acute liver failure. Manage portal hypertension if that has developed. There may be some role of hepatoprotective agents. This is mainly from the Chinese studies. Indian studies do not support it, but hepatoprotective agents like silymarin, essential or phosphatidylcholine, they may be of some benefit. So N-acetylcysteine has been advocated not only in paracetamol-related liver injury, but you could give it in non-paracetamol related injury as well. Ursodeoxycholic acid has a role to play to some extent. Cholestyramine for pruritus, short course of steroids I just mentioned, and vanishing bile duct syndrome, liver transplantation is the answer. L-carnitine, L-ornithine, these have all been tried in small groups of patients, not very of proven benefit. And if a patient comes with, after a liver biopsy, with sinusoidal obstruction syndrome, then possibly you could give anticoagulants and defibrotide. So plasmapheresis would be indicated in acute liver failure, just to buy time, acute and chronic liver failure and severe cholestasis, and liver transplantation may be required in a few patients. So our aim should be to prevent drug-induced liver injury and detect it early. Early would be if you can do frequent liver function monitoring and at least of the known hepatotoxins. There is no need to get worried because of statins. Usually, if you can pick it up early, the chances of recovery are better. In UK, where paracetamol-related hepatotoxicity was common, they have seen that not more than 16 tablets are given at one time. So the chances of paracetamol-related deaths have come down by 43%, and liver transplantation has come down by more than 61%. But certainly we need to have more biomarkers to tell us more in an early situation. People have studied salivary metabolites, and maybe AI would help us in predicting drug-induced liver injury later. So friends, in conclusion, I would say that drug-induced liver injury is fairly common in India, and do not ignore. Not all these patients of jaundice coming to you are because of the known causes. This can be one of the causes where you have to exclude a lot of other possibilities. Usually it's mild, but those who are severe may land up into acute liver failure and ACLF, and this is the group that needs careful attention. Complementary medicine is an important cause of drug-induced liver injury, so keep that in mind and try to bring out the history from the patient as much as possible. And if you, by any chance, after a liver biopsy, find that the patient has drug-induced autoimmune-like hepatitis, steroids work wonders. So thank you very much, and I'll be happy to answer any questions.
Thank you, sir, for highlighting such an important topic. May I kindly invite Dr. Pratap Singh Malhotra to the stage to present a token of appreciation for our speaker.
Endoscopic ultrasound, seeing beyond the surface, guiding precision from within. For our next session, we are pleased to introduce our very own Dr. Amitabh Jairat to please come forward and share his vision regarding endoscopic ultrasound. Revolutionizing the practice of gastroenterology.
Red line. Hello. Yeah. Thanks for the patience. So first of all, I welcome everyone and thank everyone for coming on a Sunday, which is supposed to be a day of leisure. So purpose today is not to teach much, but the important thing becomes that endoscopic ultrasound, it is a modality, and like every other modality, there is always a resistance to adopt something new into our general practice. The reason is many times the thing that it adds to the cost to the patient. Another reason is that we are not fully aware. So the purpose here becomes to make you aware that this is one particular modality which has come a long way. It's not a new modality, almost 20-25 years old now, and helps a great deal in a subset of patients in which you can reach on to a better diagnosis, outcomes, and for the patient ultimately it becomes cost friendly because he can sit with the diagnosis and at times with the treatment very quickly. So it is a procedure that combines endoscopy and ultrasound to examine the digestive tract. So we could go into the viscous with an endoscope, and with an ultrasound we can see the wall and things around it. It utilizes all these abilities. Someone had the idea that now we can go in and have something better. So this is how the procedure looks like. You can see a tube goes into the stomach, and sees the area around. We see the image outside, and the image tells us what is happening inside. So you can see here the tube goes inside, and we see this on the monitor outside. So it is always good to know how the technique works. So this would give you an idea that how endoscopic ultrasound looks from outside. You can see this is the common biliary duct, this is the pancreatic duct. So this is as we see it, and it is pretty big because we are just sitting. This is the transducer. We are in the stomach or duodenum, and here you can see something in the center, some soft mass, and here somewhere you will see a soft, a whitish image coming up, which is a small stone which we could not see otherwise, but on EUS we could see this small white stone coming up. So we could know that this is the thing which is causing all the distress. Next comes why we needed this technique. So it arose from the limitations of traditional imaging, and it was minimal invasive technique. We can go inside and then we can even sample the tissues, as well as we can drain a lot of things which are in and around the stomach area or the duodenal area. How close can we get? So these are two different cartoons. This is an ultrasound, the normal ultrasound. You can see that we go through the muscles and reach. All of these can be targeted through this technique, which is unique and novel. So the common indication, we'll keep ourselves to the relevant, which are relevant to the population we serve and more prevalent pathologies in this region. The bread and butter is fine needle aspiration. Fine needle biopsy is something which has come up slowly, and now we are able to actually get the cores out. So with the cores, a lot of problems of oncology, they get sorted. We can not only tell that this is a tumor, even the types and subtypes, they can be deciphered from that core tissue. So it is the most common reason for performing endoscopic ultrasound. We get easy access to mediastinal lymph nodes, so we don't just think it is TB, we actually prove it is TB, sarcoid or others. Submucosal lesion, as already discussed, liver sampling, pancreatic cyst, all these we get later in the lecture. These are the needles, and here you can see all we need to do is, this is the needle coming out. So this needle keeps on going to and fro in this lymph node, and in the end we get a very nice sample. So this is the sample we're getting. We're getting these cores. The whitish ones are the more relevant ones. So this probably is more of blood. So this type of tissue you get, and it is a very, very good sample for anyone to decipher. For pathologists, it is easy. Sensitivity, specificity, 90% sensitivity is very good, the accuracy is huge. And even in benign diseases like autoimmune pancreatitis, you can see 99% accuracy, which again is something which is classical. The next, we go on to liver biopsy. The traditional route was to go with an ultrasound through the skin, and now going further there was transjugular biopsies, and we went on to do the EUS liver biopsy. So liver biopsies initially were not very good, but slowly as the needles evolved, as the technique evolved, now we can do whatever are the gold standards, like minimum 20 millimeter length and 11 or more tracts need to be there in the biopsy. So we get that with the help of the newer needles, and now the liver biopsy becomes a simple procedure. So here again, in this video, you can see this is the liver tissue. Once you know which area is having lesser vasculature, you go there and you would see a needle coming out from there. The thrust has to be quick and you pick up a core for the pathologist to assess, and the yield is excellent and the results come in very quick time. So all those cases where you don't know whether it is NASH, MASH or whether it is some autoimmune pancreatitis, you can see the needle here. So this is how you pick up samples quick. Next we go to gastric varices, again a very common thing, and all of us have seen in our practice gastric varices, gastric variceal bleeding. For the record, there is 15 to 24% cases of liver cirrhosis in which gastric varices are there. There is high rebleed rates. We do a good job, like we were doing in the past with the help of glue injection. But there were some who would rebleed. There would be sometimes some vessels feeding that particular area which we will not able to see, not able to target also. So endoscopic glue injection and coil injection. You put the coil and then glue to keep the coil in place and obliterate the varices in a much better way. This is something which we started doing, and here we see the results. They were much better than what we were doing in the past. The only limitation would be the cost. Coil is costly and not every center would have this expertise, but in case you are having cases in which you believe there is some rebleed or something, endoscopic ultrasound becomes better. So this is the technique where you see in this cartoon. These are the varices. You go with an endoscope and you target the varices, put the glue and coil here, and you can see a good result coming out. Again, a very important thing, and all of us have experienced this also in pancreatitis. We see the collections coming up, and if collections stay for a longer time, we label them as pseudopancreatic cyst, and if there is necrotic material, it is called the walled up necrosis. These are important complications because in many cases you need to act. A lot of them will take care of themselves, but in some cases if they are going beyond a particular time or there are symptoms which are there, you need to act in these cases. Initially it used to be percutaneous drainage or surgery. These used to be the only two modalities, but endoscopic ultrasound has done a sea change in this particular field because more and more people are now trying to drain it inside. We have many people like Dr. Varun is here. He does a lot of endoscopic drainage inside the stomach, and we see the results are better, morbidity is lesser, things are quicker, and overall we are able to decrease the mortality rates. So acute pancreatitis, we see 80% would heal, but rest of them can get into complications. And here is where many times, this is one case which we did a couple of days back. We can see this particular cyst, and this cyst has all the necrotic material. On the top you'll see some part of it is liquefied. So this is the liquid part. In such cases, the choice would be putting in a lumen opposing metal stent, or LAMS as we call it. These are the gold standard for drainage, and most of the necrotic material can be drained through them. You can go through them also and perform a necrosectomy and remove all the necrosum from inside. This is how a LAMS looks like, so malignant, pre-malignant or benign. But with EUS, this is one field in which the diagnosis is most of the time crystal clear, not that there are not pitfalls, but we can do a lot of things, we can diagnose it, and it is in quick time. So wide range of lesions can be accurately diagnosed. Tissue diagnosis is important. Every pancreatic cyst has to be not like a renal cyst. A pancreatic cyst can have a potential to turn malignant. It can already be malignant. So here is where you cannot tell the patient that you see this thing after 6 months. No, you have to finish it up there. So this is the entire gamut. You can see so many different types: serous cyst adenoma, mucinous cystic neoplasm, solid pseudopapillary neoplasm, and you have to differentiate. Some of them are benign, some of them are borderline benign, and some of them have the potential to turn malignant. Here we see a case in which this was a cyst in an old female, and we had done all other tests, but Moment we did the cyst aspiration, all we needed was put a needle in the cyst, take the fluid out, and then subject it to simplistic investigations, and we get CA which is massively raised 2792, and we know that this is a mucinous cystic neoplasm, and then we go on to next thing what we need to do about it. This is one case again where I just wanted to show you how it would look like. This is an area which is cancerous, so this is how we see it. So this is a pancreatic cancer case. This area which is darker compared to rest of the area is the cancer, and we can easily target it with the help of needle, which we did, and found it out to be adenocarcinoma. So this I'll skip because this is all what is needed for surgeons.
And then most of the surgeons are right-hand surgeons, and there your other hand is to be used. So here we use something which we call as the ICG technique. So with the ICG, that is the indocyanine green, we could highlight the CBD, and we could then go ahead and proceed with the surgery very safely. So you can see there's a green dye which has come up. So this green shade, it highlights the liver, it highlights the CBD, and in a way it gets color coded. So once the structures get color coded, it becomes very, very easy to move forward and do the safe surgery. And surgery always means to be safety first, and then comes the rest of things. So we could complete this surgery, and within the limited time period, like we were able to complete this in 15 minutes, and this is pretty straightforward in the simple cholecystectomy. Otherwise, as you could see, there are no adhesion in there. So dissected the calyx, found out the cystic duct and the cystic artery, clipped individually, and then we removed the tissue. So then moving forward with the next surgery. So this was something, this patient had a long-standing history of a pain abdomen. She was operated almost 15 years ago for the cholecystectomy, and she presented to us with a lump in the abdomen, which on CT was diagnosed as query-hydrated cyst, but that was in the infrahepatic region. So then we went through the surgical procedure, and there was a cystic lesion which was there at the GB fossa, and we started with the device called the harmonic scalpel. With the help of the harmonic scalpel, we just can I speed it up with the video? Is there any way I could speed it up or fast forward it so that can I do it to 2x? So you could see this is a cyst which is coming up. So this was a cyst which was there and attached to the falciform ligament and to the stomach and the duodenum, and also it was stuck with the transverse colon. So gradually we were able to dissect it out from the surrounding structures, and we had to be very, very patient because since the diagnosis was a hydrated cyst, we did not want the cyst fluid to be spilled over and we later on may have a recurrence of the disease, considering that these patients might have the recurrence once the cystic fluid is there, or there might be some reaction to the body and patient may go into the anaphylaxis. So then once we separated this out, so you have to bear with me because the speed has to be like this, I cannot fast it forward. And this was the whole thing which we mobilized, and to our surprise, when we opened it up, we could see the fibers of the gauze. So there was the previous surgery which was done, and the gauze was left behind, and this case was a case of a cospribioma, so which was a surprise to us how the body can react in certain situations, because most of the times these patients, they present early with some obstruction or the gauze going into the intestine, maybe the ileum or the colon, and then patient landing up in the sepsis. So you could see this whole thing which has been released, and then after carefully dissecting from the surrounding structures of the colon, you can see that in the backdrop there's a colon there, and stomach has been separated already, and the mental regions are being taken care of. And then we actually were able to do, there are 2 more cases which we did in the past 1 month, almost similar history presenting. In one patient, the sponge did erode into the ileum where we had to do a partial resection. The other two patients, they were almost similar. In one patient, this was on the right side. In the other patient, the sponge was on the left side. They were basically the gauze which was there. So now I've just dissected this out. The whole thing has been cleared off. So then, now you could see, I'll be opening this cystic thing just to, so that now I just tried to aspirate it with the aspiration, but I could see some pus oozing out. So once the pus was there, so then I had to open it up. And on opening, there you could visualize the fibers which are coming in the backdrop. So in a moment you'll be able to see, you could see these small fibers which are coming up onto the screen. So now you could see the more and more fibers which are there. So these are the gauze pieces which were there, and a lot more pus. Now you could see the sponge coming out. So then this was something which was quite different. This patient came to us with a case of a subacute intestinal obstruction, and the CT showed equivocal results. They were not able to pinpoint that. And then we thought and went with the diagnostic laparoscopy. So you could see the gut is dilated, the colon is collapsed, so probably there is something which is purely into the small bowel. So we tried and find out where the stricture or the narrowing segment could be. So this is the segment which is non-dilated. So we started from the non-dilated segment. So eventually we realized there was a gap between the fallopian tube and the Broad's ligament. So through that, the bowel had gone in, which has caused obstruction. So now you can see I'm holding the fallopians, and there is the ovary which is coming up on the left side, and there the bowel which is almost stuck there. So once we were able to identify the cause, then it was pretty easy. We simply cut the fallopian tube. We tried to preserve it, but then it was too stuck up, and there was chances of injuring the bowel. So rather than injuring the bowel, and since the patient had a complete family, so we just went in and cut the fallopian tube, thus relieving the obstruction. So this incidence of Queen's hernia is to the tune of 1% of all the obstructions. So anyway, this is pretty rare case which we were able to do and complete it laparoscopically. So there you can see. Then this was another interesting case. So this 70-year-old male, which is a known case of a cirrhosis of liver, so came to us. This you can see there's a tumor there. So this patient with the cirrhosis of liver came to us with a history of dysphagia. And on evaluation, once we did the endoscopy, we could find there was a diverticulum which was pretty huge. And then beyond the diverticulum, there was a ecclesia cardia. And we took this patient for the imaging. On imaging, it was proved that the patient does have an epinephrine diverticulum, which was pretty large, almost 80 centimeters of esophageal diverticulum. And then even on manometry, we could prove that the patient is having the ecclesia. So the question was how to take up this patient. Since this patient was a child B patient having dysphagia, not been able to eat. So first and foremost thing was to build up this patient. So we tried and build up this patient with high protein diets and other things. Then we took this patient for surgery. You could see I've mobilized the esophagus. So after mobilizing the esophagus, we went into the thoracic cavity, and the diverticulum was too large to get hold of the things. We were not able to we were not sure where to start with the surgery or where to start with the dissection and all. So then we had to take the help of my medical colleague, who then did the on-table endoscopy. So with the on-table endoscopy, we were able to find out where the diverticulum is actually going. You can see the endoscope coming here. You could see they are trying to push it down. You could see the light of the endoscope here. So once we were able to find out the normal wall of the esophagus, then we started separating this out from the pleural cavity. And once we were able to separate it out from the pleural cavity, and we used the endo-GA staplers, and with the endo-GA stapler we were able to do the diverticulectomy, and then we went on this. Now you can see this is the diverticulum which is coming up, which is pretty huge in size. So once we did the diverticulectomy, the next step was to do the Haller's myotomy. So Haller's myotomy, I did not find it much of a challenging thing. The only concern was, since we had done a lot of hiatal dissection, and after the Haller's myotomy, the next thing would have been to do a ramp. But this patient had a unique problem of having the cirrhosis of the liver. So in a cirrhosis of liver, if I do a ramp and this patient being a child B cirrhosis, let's say he develops a fundic varices, it will be very difficult for my gastroenterology colleagues to take care of those fundic varices. So then we did something which is called as a gastropexy, where we stitched the part of the stomach to the anterior abdominal wall. So we just simply hitched the stomach with there. Now it's been 2 months and this patient has gained a weight of 5 kilograms, and we are planning to go with the resection for the HCC, which is in the segment 4, I think, which is more of an exophatic component. So there you could see this with the help of the stapler, I'm doing the diverticulectomy. Another thing which is challenging in this patient is, since this was a long staple line and patient having poor nutritional thing, so the chances of leak are pretty high. And on top of this patient being the child B cirrhosis, there are more chances of a bleed from the stitch line and anywhere. But we were lucky enough that we were able to complete these complications. And then I tried to do the literature search whether there was any case reported. But to our surprise, there is no case reported in this whole world where you have all these 3 problems in one patient. So I think that is from my side, rather than going with the video completely, this is what we did, and these are the few unique cases which we were able to do in the past 2-3 months. So thank you all for your patient hearing. Any questions or comments are welcome. So then I would like all of you to invite you for the lunch. Do join us for the lunch. And just before we do that, we had a paper and the poster competition, and the judges would be able to would be announcing the winners for this paper and the poster competition.
I just hope all the students who presented the paper and poster are in the audience. All 7 of them. Now Dr. Preeti will be announcing the results.
We have first prize for this paper poster presentation, Dr. Chandan, second year postgraduate student from SGRD.
Dr. Chandan. Second prize, Dr. Navroop from SGRD, second year postgraduate student. And the third prize goes to Dr. Simran Kaur, first year PG from SGRD.
Apart from the certificates, the Surfit Castrol City's team has also announced the cash prizes. The winners will be getting the cash prizes after this.
First cash prize of 5,000 rupees, second prize 3,000 rupees and third prize 2,000 rupees. I congratulate all of them. Kindly collect your other certificates or paper presentation also from the counter. Dr. Ritansh.
Like to facilitate our sporters, Madam Monica. No. Just don't know. So Madam Monica and colleague, so they have been the support for this organization in the background.